That the meetings are in public session and recorded, and I'm asking members please to be mindful of mobile phones and Blackberries because it does interfere with the recording equipment. I've had no apologies. Any other apologies received? No? Okay. Under Chairperson's business, I want to refer members to the written statement released by the Minister this morning, which is on page 3 of your tabled items. It's to announce the publication of a strategy for the provision of pharmaceutical services in the community, reminding members that the committee will be holding an event to engage with a range of groups from the community and voluntary sector in place of its meeting next week, and the event will run from 2 p.m. to 4 p.m. I'm going to ask members now if they could indicate if they will be attending.
Yep.
Okay, thank you for that. The draft minutes of the meeting on Wednesday the 12th of March. Referring members to the draft minutes. Are members content with the minutes?
Great.
Thank you. Item 4, members, is the evidence session on the accident and emergency services with the Royal College of Nursing. I want to refer members to the written statement made on the 18th of March and to responses from the Minister on pages 12 to 24. The committee had requested a copy of the RKIA inspection report. The Minister has advised that he will provide the committee with a copy of the report and that it will be published. It was due to be with the Minister last week. In relation to the issue of serious adverse incidents, the Minister has advised us that he has asked the Health and Social Care Board to review all emergency department linked SAIs from 2011 to 2012 to ascertain whether delay was a contributory factor and also how families and the Coroner's Office were involved. The Minister he will share the results of that exercise when it's completed. Roy, on this point.
From 2011 to 2012, why is he not bringing it up to date until current? Because there's been a very significant number of serious adverse incidents in 2013. Why is he eliminating that? That we need to follow that up.
Yeah, I think we should follow that up. You're right to point that out, but I mean, it's a very limited time frame, and there's been recent specific cases that we're all concerned about. So we seek that clarification back from the Department and the Minister. I want to refer members now to the briefing paper from the Royal College of Nursing, which is on page 26 of your tabled papers. Okay, folks, you're very welcome. We have Janice Smith, the Director of RCN NI, Mr Garrett Martin, Deputy Director of RCN, Ms Fiona Devlin, Chair of RCN Board and Lead RCN NI Community Nursing Network, and Ms Lindsay Sheeran, Lead RCN in Emergency Care Nursing Network. You're all very welcome. I understand this is the first time that you have been in front of the committee, or at least my information leads me to believe that, so you're very welcome. The procedure here is we would ask you to make a around 10-minute presentation, and then we'll open it up for questions from members. Janice. Okay.
Chair, thank you very much for your introductions, and we're very pleased to be with you this afternoon. We thank you for the invitation to meet with you. We in the Royal College of Nursing in Northern Ireland take very seriously our obligations in pursuit of our mission statement, and will work in partnership with any person or indeed any organisation in that regard. It is our view that the health and social care system in Northern Ireland is seriously challenged. For 2 years, the College is on record as expressing our concern that the health and social care system is not fit for purpose, and that nurses are being left to face the public and to apologise. That remains our position today. The totally unacceptable situation that is being played out in the majority of our emergency departments is as a result of an inability to address problems across the health and social care system. The review of public administration was intended to deliver a more streamlined and accountable health and social care system and to maximise resources. In addition, public health and wellbeing were to be placed at the centre, with a greater focus on prevention and support for vulnerable people to live independently in the community for as long as possible. The Department of Health, Social Services and Public Safety Framework document describes the roles and functions of the health and social care bodies. It clearly states that the Health and Social Care Board, Public Health Agency and trusts are ultimately accountable to the Department, and that the Department, through the Minister, is accountable to this Assembly. The framework document sets out the functions of the health and social care bodies. The Health and Social Care Board is responsible and accountable for commissioning, for performance management and for service improvement and resource management. The Public Health Agency is responsible for improvement in health and well-being, the health protection and service development, and it provides professional leadership to the Health and Social Care Board. Trusts were established as service providers, and the framework outlines their statutory obligations for monitoring and improving the quality of health and social care that it provides to individuals and for the environment of care that it provides it in. The Regulation and Quality Improvement Authority is an independent, although accountable to the Department, Health and Social Care regulatory body, established to keep the Department informed about the provision, the availability and quality of health and social care services, for promoting quality improvement and for reviewing and reporting on clinical and social care governance within the health and social care system. In all of this today, we ask the question, where is the patient or client in all of it? What is the patient or client experience, and what do we know about the quality of care and the patient or client experience? What lessons are we learning from the valuable collection of patient stories that are gathered by the Public Health Agency? The RCN is seriously concerned that targets have become more important than people, that financial break-even takes precedence over the statutory duty of improving quality of care, that care has not been organised or commissioned around the patient, and in that context it is neither effective nor efficient. There is a sense that the focus is going through the motions of sustaining the bureaucratic administrative processes and not on the patient. That messages are presented in a positive manner, even when the information raises significant issues that require to be addressed. We are measuring the wrong things, measuring compliance with processes as opposed to patient outcomes. There is a fear that the abnormal has become the normal, and there exists desensitisation to poor standards of care. Many frontline staff perceive a disconnect from those in management and leadership roles, and nurses' concerns, when expressed, are not being heard and are being referred to as soft information, and corrective action has not been taken to address concerns brought to the attention of managers. This is borne out in the HSE staff survey published in October 2012. Nurses are overwhelmed by demands put upon them. They feel demoralised, disempowered and stressed. Staffing levels in many clinical areas are wholly inadequate. HR policies slowing recruitment and freezing and removing vacant posts as cost-saving measures have resulted in nursing teams becoming depleted and in an over-reliance on the use of bank staff. The College has been unsuccessful in our attempts to highlight that these cost-saving measures, which are neither effective nor efficient in terms of costs, pose a significant risk to the quality of care, patient safety and patient experience. Work led by the Director of Nursing at the Public Health Agency and our Chief Nursing Officer has agreed in the first instance a normative staffing range for general medical and surgical wards in our hospitals. The Minister, who has been very supportive, has announced the implementation of these agreed staffing arrangements in the Assembly. The College is concerned that despite this ministerial announcement, there is a reported reluctance within the system to accept professional opinion and policy direction in relation to nurse staffing, and we will watch with interest progress in relation to implementation of the policy. We want to take the opportunity to make reference to transforming your care. The Royal College of Nursing was initially supportive of the policy direction outlined in Transforming Your Care. We are concerned that despite the appointment of a director, project managers and support staff to lead this work, we see a vision without action. Community services have not been developed as anticipated. As our briefing paper indicates, district nursing, health visiting and school nursing services have all been impacted by a reduction in their workforce to meet cost savings. And as a consequence, there is an inability on the part of those nurses to deliver the most basic of services. The College wrote to the Director of Transforming Your Care in December 2013 and again on the 24th of February 2014, raising our concerns about the lack of investment in nursing initiatives to support Transforming Your Care implementation, and we have yet to receive a response. Information forwarded to the trade unions by the Director of TYC in February 2014 outlining the TYC investment proposal gives further cause for concern. It lacks any rationale for investment and confirms that 5.5 million of the 6.7 million available money was allocated to infrastructure costs to support implementation, including external management consultancy. Northern Ireland has some excellent health and social care professionals and arguably some of the best nurses in the world. The problem is that we do not have management structures and a health and social care system that supports, encourages and empowers them to deliver safe and effective quality care to patients and clients. It is a system that is neither open nor transparent. So we say enough is enough. This is a time for strong professional and clinical leadership, staff engagement and empowerment, because this is fundamental to the delivery of safe and effective care for our patients. This will require a review of the Trust Executive Nurse Director's role to ensure that the professional and regulatory obligations of that role are clearly understood at board level, and that, in the interests of patients and clients, these obligations are given the priority currently afforded to financial balance. Reporting arrangements for nursing staff from the bedside, wherever that bedside may be, to the Executive Director of Nursing must be clearly demonstrated in uncomplicated management structures. Robert Francis QC, in his first report into Mid Staffordshire Hospital's NHS Foundation Trust, said this: "If there is one lesson to be learnt, I suggest it is that people must always come before numbers. It is the individual experiences that lie behind statistics and benchmarks and action plans that really matter, and that what must never be forgotten when policies are being made and implemented. It gives me no pleasure to come before you today with this message. However, as our briefing paper makes clear, the Royal College of Nursing does not believe that we can move forward unless and until we all admit that we have a significant problem, and unless and until we start asking the right questions." So thank you, and we are happy to answer any questions that you may have for us.
Thank you, Janice, for that very frank submission. And can I say, in starting, our admiration as a committee for the incredible, valuable work that nurses do carry out on a daily basis, and have always made that point in terms of frontline staff and the need to support that. And indeed, coming from our visit to the Royal on Monday, we could see at first hand how people are under extreme pressure in relation to this particular system. But I just want to pick up on a few things. You had indicated about writing to, I think it was the director of the implementation group on Transforming Your Care in December 2013 and not receiving a response.
That's quite right.
Well, I mean, that's completely unacceptable, and it's something that, as a committee, we'll certainly take that up. But it's unacceptable that an organisation such as yourself, or any organisation with valuable insight and potentially solutions to this issue, are ignored. But we can come back to that. I think it's very important that your paper and indeed yourself had indicated that we have become. We have moved into a place where targets are actually more important than people. And I think increasingly we are getting that message very loud and clear. And that, you know, that there has been, I think your words were, a reported reluctance in the system to take professional advice. And I think, again, that's a very challenge and obstacle but needs to be flushed out and moved to the one side. In relation to, I suppose, a very direct question, because you mentioned Mid Staffordshire, are we on the same track in terms of the processes around Mid Staffordshire?
We don't know that. That's part of, I think, the problem. And my colleagues here will speak for themselves, two of them in practice, and taking the views of members. But the lack of openness and transparency, I mean, for example, the Emergency College or the College of Emergency Medicine's report in the Belfast Trust, we never seen that report until it was given to us by the media. and yet we allegedly are in partnership working with organisations. So I'm not sure that anybody has the full picture. If they do, we're not aware what that full picture is. But what I will say is that my colleagues and I, and many of our members, were absolutely shocked to hear things being said in the media about patients coming to harm and indeed patients dying as a result of difficulties we have in our services. I mean, that was news to us, and we heard it as you heard it. So I'm sorry I can't answer your question, but I do have concerns that targets, and particularly financial targets, which we're not meeting anyway, that is the irony of it all, are coming before actually the professional advice and the delivery of care to patients.
Okay, that's been very straight. I know that you indicated in your paper as well about asking the right questions, and I think that's important advice for us all. And one of the issues was about, if we are serious about transforming your care and shifting left, it is looking at the community infrastructure. You know, and in your view, I know that you had picked up on the number of district nurses, for example, that are now in post. Is there enough community infrastructure there?
I think I'll invite the chair of the board, who's a community nurse, if she would like to answer any of those questions, and I can pick them up if Fiona wants me to address any of them.
We feel from evidence that the number of district nurses in Northern Ireland has fallen by 12% since 2008, with the workforce again beset by an ageing profile. Throughout Northern Ireland, our members would indicate that there isn't enough staffing on the ground. In effect, staffing's been withdrawn, there's no backfill, and as a result there's more pressure put on existing staff, causing them morale low, not able to meet the service that's required, and the pressures are extreme.
And just if I could come in on that, Chair, I spoke with a community nurse last night, just from one of our trusts, who was describing what it's like. She says every evening it's well past 6 by the time she finishes work, quite often not getting her break during the day, having a caseload of maybe 13, 14 patients in a day. The complexity of care of those patients is ever increasing. The demands in terms of the staffing, the lack of staffing to provide the care and spend time with patients, giving examples of patients who are end of life, who they're having to rush in and rush out of the house when families are obviously grieving and need time to speak. The nurses are finding that it's increasingly difficult to do that, and she feels that there is a risk. And this is not something just heard from one community nurse. There's also overusage of bank and agency in community, which once again is in terms of continuity of care for patients. It's basically any nurse will do, and that's not, in terms of the patient experience, something that is good quality care.
And just to clarify, the paper had said that 9% of nursing staff provide care in the community currently.
That would be correct.
Quite a stark figure. Roy, on this point,
Yeah, just very brief. You mentioned a 12% reduction in district nurses, and you mentioned there's an age profile. Has there been no attempt to replace them or retrain alternatives? Why is there not been a process of ensuring that numbers are maintained?
No, if district nurses are trained on a programme that's an 18-month programme at the University of Ulster, actually. And there is a process for looking at the training needs and ask how many do we need. And there's actually the commissioning process for pre- and post-registration nursing in Northern Ireland is amongst the best in Europe. The problem is to let nurses out to have that level of training. The resources not there always to backfill them, and the staff's not there to backfill them, and therefore the trusts don't actually commission the places to train the nurses, and nobody is keeping an eye on the overall picture. And the other thing that has happened in recent years is that the actual money that was available for post-registration nursing programmes, of which district nursing is one, has been reduced significantly in the cost-saving economic climate that we're in.
Have you numbers that sort of able to illustrate that?
Well, I can say that in 3 years that budget was 12 million, and that's not a lot for a workforce of 14,000, but 16,000 in fact. But it was 12 million, and I think now it's 7.
Thank you.
And do you see, just finally for me, and there may be other issues that I'll come on, but one of the lessons coming from your valuable experience in the paper as well is looking at not only the recruitment in its broadest sense, but the types of nurses that we required. I think there's also an acceptance in the paper that nursing alone will not solve
Absolutely.
the problem here, and it's a whole system approach that is required. But specifically, you talked about the role of the emergency nurse practitioner. Could you maybe expand on that? And you know, I'm not sure. I think it's very limited numbers of these individuals who are employed. So maybe just expand on that.
I'll defer to my learned colleague here on the left, who is that person, and she'll talk to you about that role and about how many colleagues you have trained at that level.
Emergency nurse practitioners are nurses that have been trained and are skilled to assess, treat and diagnose patients that present to the emergency department or minor injury units with a range of minor injuries and some minor illnesses. They are an invaluable resource to our emergency departments because this releases our medical staff so that they can assess those patients who present with more serious conditions. Our members definitely feel that nurses can actually give more as well. Across in the UK, we have seen the rise of advanced nurse practitioners, which are nurses that can also assess, see, treat and discharge patients who present with more complex medical conditions. I think it's what's important when we're looking at our workforce is that emergency nurse practitioners should be separate from our nursing workforce. Often when we're looking at the nursing establishment within our departments, our emergency nurse practitioners are counted in with the nursing numbers. And these are a valuable resource that we need as well as the nurses within our departments.
Okay, and just to clarify, because the Minister in his statement last week had talked about the advanced nurse practitioners and talked about the appointment of 2. You're indicating it's different, the emergency nurse practitioner?
Yeah, the emergency nurse practitioner role and the advanced nurse practitioner role are 2 valuable roles, but they are quite different. The advanced nurse practitioner role will assess patients with more complex conditions, those conditions that traditionally the doctors will see within the department. Examples of that are patients presenting with chest pain, patients presenting with respiratory illnesses, very much what a lot of doctors traditionally would have seen. That's the advanced nurse practitioner kind of path. Unfortunately, within Northern Ireland, we don't have. It's not that we don't have the suitable courses. The training and education for advanced nurse practitioner role is that of at master's level, and currently we don't commission for master's level training courses within Northern Ireland.
So those 2 nurses actually, Chair, are training in England at this moment in time. They're undergoing training, and there are 2 of them, and they have been on that programme for about a year.
I think 18 months now. 18 months now, yeah.
Which probably just finally, because it's quite stark that that training isn't even commissioned here. I have to say, but I noted in your paper as well that you talked about nursing care in terms of ratios. Nursing care or nurses care for 6 patients, and over 60% have degrees. Then the risk of hospital deaths would be 30% lower.
That is recent research that has just been published. We live in a world where professional opinion is perhaps, well, I'm maybe getting older now, but our professional opinion now in itself, people are saying, and where's the evidence for it? And thankfully, there is emerging evidence now, and lots of it, about the effects of nursing staffing levels and the outcomes for patients, because that's the most important thing. That research that you're alluding to has recently been published in The Lancet, and it has been able to demonstrate quite clearly across several countries that once you start to educate nurses to degree level, and there has been a lot of controversy about that, as you're aware, that once nurses are educated to degree level, the patients that they care for, their mortality rates drop. So basically what they're saying is the more robust the academic preparation and the practical preparation of nursing programmes, the better outcomes there are for patients, and that's what that's alluding to.
Okay, thank you for that. Now I have a number of people that indicated on that.
Supplementary on this area again. In your paper, you've indicated 21,000 over a total of 70,000 at one accident at an emergency unit were treated by an emergency nurse practitioner. That's a quarter of the patients. Yet there's a shortage of consultants, and that's one of the critical factors. So my question is, has there ever been a shortage of nurses willing to do this course and to take on this role? Because we're told there's a shortage of consultants, yet a quarter of the patients can be treated by emergency nurse practitioners. Has there ever been a shortage of applicants from nursing to take on this role?
I don't think there are a lot of emergency nurses that would aspire to be emergency nurse practitioners, but again, it comes back to the commissioning of the courses. It is my belief that there is one health trust within Northern Ireland this year that's not actually commissioning the course. And a lot of reasons for that is the resource to allow the nurse to go out to train to be an emergency nurse practitioner. There isn't that backfill to allow the nurses to go out to develop. There are lots of emergency nurses who are very capable and willing to take on these roles, but the availability of the course being commissioned is reduced.
And has there been turnover of those who've been trained? Because again, we've been told that emergency doctors, many of them have moved on elsewhere. So what has been the example of in terms of emergency nurse practitioners? Have they remained in Northern Ireland and treated patients here?
Yeah, they fairly much have stayed, and I think that's one of the things in terms of sustainable services. The nursing workforce is much more stable and sustainable, and I think the evidence that we've presented in the paper demonstrates the potential and demonstrates what nursing staff, whenever they are given the opportunity, when they are supported, and when there is backfill, that they will provide an absolutely excellent service, and that's worth investing in.
Okay, thank you for that. I have Kieran next.
Yeah, Chair, thanks very much. Thanks very much for your presentation. I mean, what you have said to this committee, in my opinion, was horrendous, but it had to be said. We know what has been, well, we think we know what has been going on, and you have certainly, Janice, in your presentation, made no attempt to hide what's going on. We're very grateful to you for that, because everyone in this room has the utmost, as the Chair has said, admiration for the nurses. We see the work the nurses has been asked to do and is doing, and I have used the term burnt out in some instances. And if people are not listening to you, and you're the representative of the nurses, I don't know where we're going to go from here. And surely this forum that you have, and I don't know why you haven't been invited in before now, but you're here and you've said your piece, and I think that those that are listening has a duty to act on what you have said. I mean, for instance, the Chair has early on you said about a letter advocating the problems to the Executive Director of Nursing, and you haven't had a reply in 3 months.
Yes,
I mean, that, Chair, is horrendous and unacceptable.
Yes, it's a letter to the Director of Transforming Your Care, because we were concerned that whilst we're trying to get patients their care closer to home, which we believe, when appropriate, is the right thing to do, we need to have a workforce that is able to do that. And instead of seeing that workforce increasing, we were watching it decreasing. So our question is, what resource in terms of transforming your care is going to go in to support nursing to actually deliver care closer to patients' home? That's the question that we wanted answered, and as I said, we didn't get an answer.
You haven't got an answer. That is absolutely shameful. Just going on the transforming your care, we have been told over and over again from day one, transforming your care was not about saving money. Was not about saving money. John Compton told this committee on more than one occasion it wasn't about saving money. But it seems to me the outworking, we're into 2 years of transforming your care, and it seems to me to be getting worse and worse and worse. I mean, would you support the slowing down of the programme Transforming Your Care until, well, before it gets too far through, when there is a crisis on top of a crisis?
Well, if we knew what it was and what it meant and what it looked like, we would answer that question. Our problem is we don't know what it is. We don't know what the model looks like. We don't know what direction it's been taken in. What we do know is we see things being presented as these innovative things are happening in accordance with Transforming Your Care. We don't believe that. We believe that some of those things that we see would have happened anyway. We see nurses and other health and social care professionals who are very creative, who are working closely with people, who with those people know how to make the system better, how to make the service better. They innovate, they do it, and that is transforming patients' care. There is no doubt about that. My concern is if we don't do the bigger picture stuff about how do we, if we have got an ageing population, a larger population, more demand, and let's face it, less money, and we live in the real world, unless we're going to cut the cake differently, there is no doubt about it, we are financially challenged. So if that is the case, then where is the bigger picture in the model that is actually going to deliver that? Because if we don't know that, how have we costed it, and how do we know how much it's going to cost? And that's our concerns around Transforming Your Care. Nobody can tell us that.
Right, okay. And finally, Chair, you did use the word seriously challenged.
I did.
I think you're being a bit modest there. I think you're at your wit's end in relation to where, we see almost on a daily basis the care that the patients are not getting. They should be getting, and they would be getting if you and your organisation had the means and the resources to provide that. That's what we're all about, and we're all wanting. Finally, whistleblowing. I don't like the term whistleblowing, but in recent times we have seen seen good things happen as a result of people coming to their line manager and saying things like that. Are you happy and content? Because the Minister has always supported whistleblowing. But, we see so often people that want to do that, want to do the right thing, are penalised, are punished, lose their job, etc. Are you fully supportive of people coming forward, telling what is wrong in order to get it fixed?
We absolutely are. We have about 3 years ago, maybe 4 now, issued in Northern Ireland guidance to every one of our members to help them to raise their concerns appropriately. We have a team of staff in Belfast who will speak to any of our members. Indeed, I'll do it myself if they contact the college about to support them to speak up and do the right thing. Because the thing that we really, really need to remember here is registered nurses are obligated to do that. It's not optional for them. They are absolutely obligated to do it. So we do that. Nationally, we have a whistleblowing helpline as well. And so, yes, we absolutely agree that people should speak up. But I would say this to the committee about raising concerns. If you consider the context in which health and social care professionals, including nurses, are working today, and if you look at the caseloads in the community that are utterly impossible and that they're raising their concerns every day, many of those nurses don't even have a mobile phone. They don't have access to a computer. 16 of them will be coming into an office to access it to get information. You go into the hospitals, you look in all those wards where they've put up extra beds for patients. There's no privacy screens, no call bells, blocked fire exits, not enough staff to look after them. We're transferring patients, multiple transfers during a hospital admission, many of them older, vulnerable people, and indeed, on some occasions, from one hospital to the other, late at night, in the dark, in a cold ambulance. Now, I ask you, if those are not concerns, what are concerns, and what message does that give to staff? That it's okay to do that, when it is absolutely not okay to do it, and that's what nurses are concerned about. They say that the abnormal is becoming the normal, and people are getting desensitised, actually, to what is totally unacceptable. Men in beds beside women in our wards. You
and
know,
in
so-
corridors.
And in corridors, and it is totally
For
unacceptable.
a week at a time. It was shocking. Just finally, the 40 nurses that the minister promised us, where did they come from? All, so quickly.
Well, I actually am going to meet with the Director of Nursing in the Belfast Trust tomorrow to have a conversation about that. I'm not sure that that is new money and it's 40 extra nurses. I'm really not sure about that. But what I do know is that those nursing teams in those clinical areas have been under pressure for a long time. The spike, and whoever advised the minister it was a spike, and I've had this conversation with the department. I don't know who did that, but that was wrong. It wasn't a spike. It was increase in pressure. It was building, and the nurses knew that, from October last year. Some of those teams are staffed to about 50 to 60% if you're lucky, and the other 40% of the staff comes from the bank. Anybody and everybody on a daily basis, weekly basis or whatever. And that's because posts were frozen. The vacancies, when somebody left, they were frozen to save money, and they're trying to fill them from the bank. I believe what they may have done, but I don't know this till I check tomorrow, is they may have said, after the RQIA inspection, and we were raising those things from October last year at least, with no success, but after the inspection, what they may have done is said, we need to staff these teams properly, and we're going to now convert the money, because it wasn't saving money, that we were using these temporary, filling in these posts, into a proper nursing team, and that's what should have been done in the first place. So I need to clarify that.
Right. Thank you very much.
I'm sorry, if you don't mind, just if I add to that. I think, as Janice says, there's a lot of questions still to be answered around that, but I think it shows that that was a reaction to a crisis. It shows how there have been failures of planning. We could ask the question, would that money have been better off invested in 40 community nurses to prevent patients, for example, coming to the emergency department in the first place, to support patients coming home from hospital, all those other things in terms of planning, and back to the previous point as well around commissioning. I think what we see in commissioning is a failure, failure in terms of planning. If you look at unscheduled care, it is 80% at least predictable in terms of the times of day, the days of the week, the months of the year. Surely, if planning was what it should be, we should be able to match the workforce to meet the needs of the patients and meet the needs of the service in a way that prevents the crisis emerging that we've seen played out in recent months.
And can I just
Sure,
come in there as well? I think that we need to note that every major emergency department in Northern Ireland is under pressure with regard to staffing, and definitely the members are concerned with regards to the lack of effective workforce planning.
Thank you for that. Fergal next.
Thank you very much, Chair. And the Chair and others have reflected on the fact that you were frank. I could describe it as blunt and direct, and for that can I also thank you. It's a £4 billion a year, almost, life and death health service, and unless those at the front line are direct and frank with the committee and the department and the minister, then I don't think we will have change. I was going to ask, on the basis of some of your questions, about whether you were being listened to or not, but you've asked in your submission 22 questions, concluding with who is accountable. And would I be right in describing that in its totality then as an indictment of the present situation?
We believe we know who's accountable, and that was the purpose of outlining that in my verbal submission here at the outset of this evidence session. But I'm not sure that we hold people to account as we should do, if I was truthful. I don't understand how we got to a position where professionals, where their voice is not being heard. I don't know where we got to a position where support services have become the control mechanism and controlling how we staff professional teams and how we deliver care to patients. So I'm very clear as a nurse what I'm responsible and accountable for. I'm very clear as the director of the organisation that I work for, hence why I had to come today to give that message. And I do believe that it's for others to look at their responsibilities and accountabilities and to ask themselves the question, who is accountable for getting us to where we got to. And I do believe that that my organisation, the people who work in and the members that we work in partnership with, including our board here, have done their bit to try and say to people, this is not the way to do this and we need to take stock and do things differently around here. But unfortunately, we have not had much success, I don't believe.
Can I draw a straight line from your accountability questions to your concluding remarks, which were whoever's responsible should now start to admit that there is a problem? At its highest strategic level, in your view, what is that problem?
I think that I've had this conversation with many people. If I could have come here today with my colleagues and all the expertise that we have in our college, and that's a lot, and given you on 2 sides of an A4 paper how to fix this, we'd have done that long ago. I do believe that, and I do feel duty-bound to say this, that the Minister and certainly the Chief Nursing Officer at the Department and indeed even the Permanent Secretary, I do believe that they do understand the problem and that there is a will, an absolute will, to support nurses and others to provide, a quality standard of care to our patients. But I have said in the paper, in terms of nursing, and nursing is not the solution on its own, we do need to look at the Executive Director of Nursing role, and we do need to understand that their obligations in terms of their professional obligations for standards of care and their regulatory obligations and their duty of care to patients, that needs to be given the same weighting and credibility at a trust board as does the financial requirement, for financial break-even. And I suppose I would say that trust boards, the boards of all of our organisations, have got obligations and responsibilities, and I think that people need to review what those are. I really do. But I think it's for other people to do that. It's not the job of the college to hold people to account.
Okay. And 2.5 years into a TYC process, the RCN, and you've thought long and hard about this, I assume, in terms of your submission and your direct submission, to describe TYC as a vision without action, and you don't know what it is and what it's meant to be and what direction it's going in. But specifically, as frontline operators and you as a union monitoring this, are you witnessing any systems in place that measure any of the progressions within TYC?
Certainly, I'm not aware of them, and what we will say is, we have taken lots of hospital beds out for older people, and that perhaps was the right policy. It's not the best place to care for older people, and we would accept that. Our problem is we don't know what alternatives were put in place and what are the models of care in the community to care for those people. And that has resulted, in our opinion, in them getting care that's wholly inappropriate. So, no, in all the deliberations that we have had, it is our view there should have been a model, and it should have been a strategically, regionally led model of what we were trying to achieve with transforming your care, and then the resources to deliver it should have been invested in that. Doing it the way we're doing these little bits and pieces, I don't know what the money's been used for, and I've already said in this submission about 5.5 million of 6.7 million appears to be going to infrastructure costs to take people out of their jobs, to develop implementation plans. What is all of this about, and what difference is it making to the people?
And just to come in on that as well, absolutely, we see structures and groups who meet, but when you speak to frontline staff, you may see some examples of small pilots or small pieces of work where, once again, there seems to be an idea that on paper may work, small bit of investment in it, but in terms of any outputs in relation to patients, what we're hearing from our frontline staff is that they don't see anything actually happening on the ground.
Okay, thank you very much. And just finally, Chair, if this was a widget factory, we might be able to sustain some of that going forward. But as I said at the outset, this is a life and death service, and when measurements or non-measurements and systems aren't in place, then we have to ask questions.
Absolutely.
Thank you, Chair.
Okay, thank you. Fergal Gordon.
Thanks, Chair, and thanks very much for coming in today. We do appreciate it. A couple of things. Could you clarify, first of all, please, Janice, just how many staff you do represent in Northern Ireland?
We have got about 14,000 nurses in membership of the Royal College of Nursing in Northern Ireland.
Right. And that's all grades of nurses?
Yes, all grades of registered nurses, and we have a small number of healthcare support staff, nursing support staff.
In relation to total nurses, is it true to say that we've had a significant increase of nurses across all grades in, say, the last 3 years?
Now, when you say a significant increase, there has been a decrease in the numbers of nurses that we have trained. Over the last 3 years, we've decreased those numbers. If you look at the
overall, though, in the grades, is it true to say there's been 500 extra nursing places in the last 3 years?
I'm not honestly sure that is quite right. The only official statistics we have is the workforce census that the department publishes, which is accurate. Actually, I'm not calling into question in any way that it's not right. But I don't know that we've had an extra 500 nurses in 3 years. That may be the case. That may well be the case. But if it is the case, those are nurses that are being employed via the banks in our trusts, and not nurses that are being employed in permanent contracts in nursing teams to create.
Is there not a spread, though?
Ability.
Is there not a spread throughout the organisation of these nurses?
No. I would say if you ask the Trust to produce for us the advertisements that they've placed in the last 3 years for registered nurses, what you will find is each Trust has probably placed 1, if not 2 advertisements in a year, but no more, I would suggest, for Band 5 nurses, which is the lowest band of a registered nurse. And the advertisement will say permanent, temporary, full-time, part-time, all clinical areas, nurse bank. So they set up these panels over days, they interview all these people, they come in, and then most of them get a letter to say that we don't have a permanent position for you, but if you'd like to work in our bank, we can give you a contract for the bank. So you've got thousands of nurses registered.
A lot of these posts could well be within the bank.
Pardon?
These posts that we're talking about could well be within the bank.
Yes, yes.
And sorry, can I just come in on that as well? It depends on the point that you start measuring, because there was a peak in 2009. There was a reduction, from memory, I believe almost 3% in the overall workforce from 2009 to 2011. That has rose again to figures that are basically the same as what they were in 2009. So yes, there may have been an increase from 2011, but there was a decrease between 2009 and 2011. But it would be worth checking out those figures.
Okay, thanks very much. One issue of great concern is this issue of lack of communication from people like yourselves and your staff through to senior management. How, as an organisation, do you communicate with senior management, and do you it on a regular basis?
Yep. The Royal College of Nursing has a Nurse Leaders Network, and that Nurse Leaders Network, every Executive Director of Nursing in the Trust are members of that network, and we do have very good working relationships with them. They're constructive, and sometimes we have quite healthy debates, but we have got very good working relationships with them. The Chief Nursing Officer also attends that network. They recognise that there is a problem raising concerns. The network have asked that we lead a piece of work, and that is currently being developed to go out and engage with frontline staff. The Chief Nursing Officer herself met with nurses from Northern Ireland at Congress last year. She was just appointed. She met with the Emergency Care Network nurses. She's met with them on 1, if not 2 occasions since then. So it's not a matter of those people not engaging with us and engaging with nurses either. The problem is the management structure that exists in our organisations, and how nurses, and that was in my speaking notes, how nurses can communicate from the bedside, wherever it is, in a community or in a hospital, right up to the Director of Nursing, Executive Director of Nursing in Trust. That is far too convoluted, far too complex, and that is part of the communication problem. But if you're in a situation where you're firefighting every day, there ain't much time to take time out to look at what you're doing, to discuss are there alternative ways to do it. And that is part of the problem as well. I mean, the system is under so much pressure. There is only time to look after patients, try and prevent no harm coming to them, and not much time for anything else.
Have you as a union put forward ideas on improved communication?
Absolutely.
You have a lot of full-time people there that should be engaged in.
We have got 4 full-time employment relations officers in the Royal College of Nursing. Those 4 people are in our trusts and in our independent sector facilities, and indeed the employers also fund some of our full-time stewards to carry out a trade union role, and they are all working flat out.
So this thing we hear about in the media, that the management, senior management, are not listening to frontline staff. Is it true?
I believe absolutely it's true. That's what our members tell us, and I can only say to you that we've been raising concerns, and it's on record, and people can see it at their will. We've been raising those concerns, and I have to ask the question, are they listening to us? And if they don't listen to us, what hope has the frontline staff got?
Okay, thanks very much. Thanks, Chair.
Thank you, Gordon. Mickey?
Yeah, thanks very much for the presentation. I think you've rightly articulated a very bleak scenario. I think just some of your remarks, I mean, you've summed up, I think, transforming your care very well, vision without action, because there are 99 recommendations, which probably seemed like a good idea at the time, aspirational. You cannot develop those recommendations without, and you have mentioned that community services are not developed, so you haven't got the infrastructure there which will take over from the acute end of it. You've talked about disconnect with management, you've talked about no openness or transparency, and you've also talked about the trust boards really abdicating responsibility and accountability in that sense. Is this endemic to all the trusts, do you feel? Because I know it was mentioned about the emergency services departments right across the north. I mean, I would be familiar with Daisy Hill, and I know they're under tremendous pressure, and we saw the Royal on Monday. It just seems to be a continual problem. But I don't understand how you can have a health system which absolutely ignores frontline staff and ignores professionals who are working flat out to try and maintain a service which is really crumbling around them. And I don't want to be too prescriptive, but that seems to be rightly the case that you're presenting.
Yeah, I don't think that we're in a position today to trust by trust, give a report of how we think they're doing, and I don't think that that's probably not what you're asking us to do. But what I will say is that we know that there are areas of good practice in every trust. We know that some trusts appear to be managing better than other trusts. But what we feel to be able to do is to look at areas of practice in whatever trust that do appear to be working, and as a Commissioner to look at those closely and to see can those be replicated across Northern Ireland. So if it's working there, why are we not applying that to somewhere else? So whilst the presentation today might have been bleak, I will say that there are areas of excellent practice here in Northern Ireland, and there are some trusts delivering excellent services to patients. It's not all bad, but I can't absolve myself of the responsibility of portraying to you how concerned nurses are about the system that they're trying to operate in.
I think there's an acceptance that we have very excellent professionals. You did say the Minister is supportive. I've put a question mark after that, because where does the buck stop? Ultimately, because you can be supportive, but you're trying to implement an aspirational system, and I mean the first hurdle fell with residentials, so that it has kind of degenerated, for want of a better word, since, and ultimately people are suffering because one of the other things you said was it should be people before numbers, and it seems numbers and targets, and the Chair did mention targets earlier, are paramount, without actually the patient being the priority and at the forefront of everything that you do, which I know they are, but you're being let down. It seems to me that you're not getting the support. You're not getting the recognition, because if you have a disconnect between yourselves and management, then that's a serious problem, because you're not being listened to, obviously. And that needs to be addressed. And I mean, it's a responsibility for us here as a health committee to try and do something to rectify that situation. It's incumbent upon us, otherwise we shouldn't be here. Simple as that. But thanks very much. It's not all depressing, I'm sure.
No. Okay.
We live in hope.
All right. Are you finished there, Mickey?
Yep, thanks.
Sam?
Thank you, Madam Chair, at last.
Apologies.
Thank you very much for your presentation, but I wish you hadn't had to make it to us, to be quite honest with you. And
So do we.
personally speaking, I feel gutted that you've had to come through this. And I hope this committee, as a health committee, has the common sense to write to the Minister and express our concerns of just what's going on, and for a full investigation. It's not good, it's not healthy, but we want the best for our health, for our community. And I do appreciate you coming and being so frank with us. It's welcoming, it's not good news, but it's up to us to see it sorted out. Thank you very much indeed, and I hope that's followed through.
Thank you, Sam, for that. I have Jim. Yep.
The Minister, in his statement, said that there were significantly more nurses now practising in Northern Ireland than he came to his post in May 2011. Now, he didn't differentiate between bank nurses and full-time, long-term contract nurses. Do you accept that that is the case, that there are significantly more nurses now than there was in May 2011?
If the Minister said that, yes, I do, because I've never known the Minister to say something that wasn't truthful, actually. But I think that, Jim, the issue for us is the front line don't feel it because of the way they're being deployed. Sorry, the way they're being employed and deployed. That is probably the issue.
Right. You also seem to indicate that you feel a bank nurse is of less value than a full-time permanent nurse, but most of these bank nurses actually at one stage were, or maybe still are, permanently employed. I mean, a lot of bank nurses are people who do work in hospitals and then put themselves down for bank nursing to supplement their income. I mean, most of these bank nurses would be well known to you, indeed many of them would be your members.
2/3 of the nurses employed in banks and or trusts are actually the Trust's own employees. The reason that they're employed in the bank predominantly is because when Agenda for Change was implemented, nurses for the first time were entitled to be paid overtime. They were not entitled to that before. So if a nurse works 37.5 hours, which is full-time, once they work over those hours, they're entitled to overtime. So if a nurse wants to do an extra shift in our trusts, they have to do it through the bank, and they get paid a flat rate and not overtime.
Yes, but so therefore, this is Nurse Jones who's working at Hospital X Monday to Friday, and then puts her name down, or he, though they're mostly her, of course, puts her name down for, say, a Saturday shift. So that's a very experienced, capable nurse simply doing extra hours. So therefore, they're not inferior staff.
If they're working in their own team, of course, that is absolutely no problem, although I don't see why sisters should have to go through a bureaucratic process to get Janice to work an extra hour on Saturday, just because, you know, they have to do it through a nurse bank and all that nonsense that goes on. But the problem with that is that people assume that a registered nurse is an all-singing, all-dancing registered nurse. A registered nurse who works in theatres has very different skills and attributes than somebody who works in a care of the elderly setting or indeed in an emergency department. And the problem is that when you go to the bank to look for a nurse, you get a registered nurse, and the emergency nurses in particular complain that the nurses that come to fill the gaps, many of them are people who have never been in an emergency department before, let alone who have the skills and attributes to function properly as an emergency care nurse. And finally, I will say, the RQIA inspection report isn't published yet, but my understanding is that it will allude to nurses working in an emergency department above their competency level. And that is very concerning. So it is not a safe way to staff clinical areas unless you can assure yourself that you're getting a nurse with the skills and attributes to go and work in the medical ward, in the psychiatric unit, in the theatres, who has actually got that experience and those skills.
Well, surely the simple solution to that is that when the request goes in, you actually say, we want a nurse with that experience.
They're not there. Remember, you're not obligated to do your shift in the bank. You have no obligation whatsoever when you get a phone call to ask you to come to work to come. And they struggle to fill those shifts, and many of them go unfilled.
I mean, I've been in this committee 5 years for my sins, I think, and I was at the very start of the TYC process the whole way through. I have to say, in the early stages, I detected a much more positive approach to TYC from yourself.
Absolutely.
You and I have spent many hours together at various meetings.
Absolutely.
And you've never been shy and retiring about putting your views forward. I think that's about the one thing we'd all agree on. So, 4 years later, 3 years later, you seem to have had a sort of a shift of emphasis on
Absolutely.
TYC.
Because I saw the vision. We, our members, considered that all very carefully and wrote a very robust response to that consultation, and we were supportive of that policy. The problem that we have is we don't see the outworkings of it. We don't see the services in the community for our people. We see REDs backed up with people who, quite frankly, shouldn't be there, who should have services elsewhere, who should be able to access services via another route. We don't see any of that transformation taking place.
Would you accept that it's inevitable when you're having such a sea change in health and social care provision, that when you move from the old model to the new net model, the interreg period is bound to have technical and teething difficulties? You accept that we're shifting, it's such a major shift, you're bound to have problems occurring?
Absolutely. We wouldn't dispute that. But we don't believe that that's what we're seeing. We believe that we are seeing a policy and a vision, but we don't see the action to support it for whatever reason. We believe it's because there's not a strategic direction, or the model was never properly agreed, and therefore how do you deliver something when you don't really know what it looks like and what it smells like and what it feels like?
Do you also accept that within days of you making these views public, the Minister came and faced your members in quite a heated meeting?
I have said earlier, and it's something that the College is very, very careful about, but it is a matter of record that Edwin Poots, the Minister, has been absolutely supportive of the Royal College of Nursing and of its members, has been accessible more than anyone else, and that is not an issue for the College, and it's not a reflection of his relationship and his commitment to do the right thing for nurses and for patients.
Well, I appreciate you putting that on the record. Yeah. I've spoken to him since that meeting, and unlike today, he didn't walk out trying to catch the nuances of what you were trying to say. No. It was a difficult meeting for him, and he'd had a lot of very articulate and forceful people giving their point of view. So, have you had any contact since that to find out what he's doing to take on your views and try and improve things?
Yes, we noted his statement to the Assembly recently. People will be aware that there is a summit being facilitated and chaired by the College of Emergency Medicine on the 9th of April, which we will be there as well. And I do believe that the Minister is monitoring the progress in that regard to make sure that that work is taken forward. I should say as well, the Chief Nursing Officer has worked with the Emergency Care Network, and they're going to lead a piece of work on her behalf with the Northern Ireland Practice and Education Council for Nursing and Midwifery to look at a framework for nursing in the emergency services. So there are, people, and I said that earlier, who are truly trying to do the right thing, but this will take really strong leadership and a steady hand to start to first of all say we've got a problem, and I think people have done that now, and what actions are we going to take, and who do we need to engage actually to start and put that right.
Thank you.
Thank you. Just finally, Roy, did you want to go ahead? Yeah.
Before you said that, I thought I was indicated I want to speak.
Sorry, I must have missed
One of the issues that you have raised on a number of occasions is that management hasn't been listening to frontline staff, and you've also indicated you've raised your concerns in writing. What has been the response to the issues that you've put in writing to management?
I'm not sure that, as I said to you earlier, I think you're referring particularly to the ED department in Belfast, and it was a matter of record that we said that. I'm not sure that we got that right, and I have asked, we started to raise concerns at the end of October, And for whatever reason, we didn't succeed in conveying, the seriousness of the situation. And we had the major incident called in January, I think it was. So the Director of Nursing and I are going to sit down tomorrow to look at that and to reflect on why, when the Royal College of Nursing raised those concerns, were we not able to achieve the additional staffing for our members to support them to deliver care to patients? Why did it take an RQI inspection and thought to do that? And I think that is an issue that I do want to have that conversation with her about, and she has agreed that to do that, and we'll be having those discussions tomorrow. So I'm not quite sure. I would not like to make assumptions about why, when we raise concerns, that people don't, that we believe our voice is not heard or it's heard and ignored.
Okay. I'll leave that when you seem to be
Yes.
content with the method
Thank you.
you're intending to take it forward. In paragraph 17 in your paper, one of the issues you've raised is that the current genetic recruitment of Band 5 nurses in terms of the pathway to emergency care nursing. What are the alternative mechanisms that may be used elsewhere, and why is this a problem?
So you're alluding to the fact that the career pathway in emergency care nursing, that the current generic recruitment of Band 5 nurses. This goes back to the discussion that we were having that I was responding to Jim. When at the moment when they advertise for nurses, they just advertise for nurses. And some nurses have got, as I've said before, the personality and the skills and attributes to care for older people, to work in a very fast-moving theatres where actually patients are not awake most of the time, to work in outpatients departments delivering services there, or to work in RED departments or in general wards. But nurses have aspirations for their career, and the way that we recruit them absolutely denies them of the opportunity to look to see where they believe they can best contribute. And so what we're saying is that there are nurses who would like to work in emergency departments. Nurses are deployed in emergency departments on temporary contracts through the bank. Then a permanent contract comes up, they're on a waiting list. That permanent post is in, where, Lindsay, would you like to say? Where was the last one? In a surgical ward. So the nurse that has been in the emergency department for 2 years, trained up, skills and attributes, the next thing we know gets a permanent post. Who's going to turn it down? So they're off to the surgical ward. Next thing is somebody else is pulled from the bank into the emergency department, and we start it all over again. Meanwhile, there are people who are in the emergency department who want permanent posts somewhere else, and they can't get them, and they're stuck in the emergency departments. So it's all about, again, it's the same as the patients. It's about numbers, and it's not about people. It's not about their career aspirations. And please don't misunderstand us. The Royal College of Nursing is very aware that the Health Service is not here to give people careers and to meet their aspirations. But I do believe that you can do both. And there is very good research now from the King's Fund Point of Care Foundation that shows why staff matter. If you look after the staff and value the staff, the patient care is better, and there is research to prove that.
You've indicated again in your paper that there's emerging evidence of difficulty of filling posts in some of the medical admission units and emergency departments.
There is, that's quite correct.
How big is that difficulty?
Well, if you were a young nurse or a young doctor today, would you be rushing to work in those clinical areas under that pressure? And we need to be very careful when we're doing that to nurses and to other health and social care professionals, that we're not making environments totally unappealing. In fact, too stressful. They're saying, do you know what? Don't want to go there. And that's what's happening with some of the bank nurses. They're asking, when they get a phone call, I've got a bank shift for you, where is it? And they're saying, well, do you know what? Don't think I'll take it.
You've indicated that 50 to 60% of the nurses may be actually full-time nurses, and the rest of them are bank in emergency units. And
yes, the teams. Some of those teams, they range from there's 60% capacity, 70% capacity. The other 30% is made up from temporary staff from banks or agencies.
And your paper also mentions assistants should be trying to avoid staff burnout. Are you receiving evidence from your members of staff burnouts who are working in emergency departments?
Garrett will answer that because he does our employment relations work, but there is certainly evidence of that.
Yeah, we've certainly have had members come to us who in distress states and members who have went off on work-related stress. Certainly it is reported that sickness absence levels are increasing as a result of those pressures. So that's something that certainly, I think in terms of evidence, and Janice mentioned about the King's Fund and Point of Care, Jocelyn Cornwall's research about investing in staff and staff engagement and how that transfers to compassionate care being delivered, and that's certainly something that we're seeing as well.
Okay, thank you.
Okay. Members conclude. Just finally, from my own point of view, if in terms of the summit,
Yes.
that's been announced, and we're recognising that there's a whole system approach needed to this. I think there's recognition of that, and it's very clear, certainly from my point of view, and I think it's shared among the committee members, that part of the failing in transforming your care is that there is absolutely no outcome framework attached to it. And you've alluded to that yourself. There is nothing that gives us, any of us, confidence that the shift left will have X, Y and Z outcome, and that's a challenge. But if there was specifics that you would request coming out of the summit, what would they be?
I think the emergency care nurses here will speak for themselves, and even maybe the community nurse, but I think coming out of the emergency care summit needs to be the recognition that just looking at emergency care and putting extra doctors and nurses in there is not the answer, and that we need to stop moving to solutions before we've done proper diagnostics about what the problems are. And that's the reason for the 22 questions. I didn't realise it was 22 in that paper. So I would be hoping that out of that will come some kind of collaborative. And I certainly would hope that the Royal College would be included in that, ourselves, the Royal College of Nursing, and we could get round the table to look at what do we know about the people who are coming to our emergency departments, and if that's what we know about them, what other services could we put in place that actually would care for them without them having to come there, and return emergency departments to the purposes for which they're meant, and that is to care for people in emergency situations.
So it's effectively a regional review of what exists, where the gaps are, where the gaps can be plugged, what are the infrastructural needs, and then I suppose the types of recruitment that is required as well, the types of nurses. Bearing in mind it's not only nurses, but the types of nurses that will be required.
You cannot plan a workforce until you know what the services are that you want to deliver with it. And I suppose I should say that to the committee before I leave. The Chief Nursing Officer, since her appointment, and indeed under the instructions of the Minister, has set up proper workforce planning groups for nursing. And those are moving at quite a pace now. So, and we're involved in all of that. So we had no workforce planning for 3 to 4 years for any profession, not just nursing. So he has that underway now, and but we need to know what the models. We're back to what are the models that we want to deliver care, and if that's the models, then what kind of healthcare professionals do we need to deliver that?
Okay. That's,
Just one very this isn't a question, but just something to be left hanging. I mean, does that all amount to, in our minds, a review of transforming your care? But I don't need an answer to that.
That's something I suppose that we will need to reflect on. Well, I want to thank you all very much. That's been very useful. Unfortunately, maybe not something that's new to us, but we appreciate your honesty and frankness today, and we'll take on board and reflect on the information that you've provided.
Thank you.
Thank you. Okay, members, moving on to item 5, which is the evidence session on A&E services with the Belfast Health and Social Care Trust. Referring members to the briefing papers from the Trust at page 40 and page 6 of your tabled papers.
No problem.
Okay, folks, you're very welcome. We have with us today Colin Donaghy, Chief Executive, Tony Stevens, Director of Medicine, Bernie Creaney, who's Director of Nursing and User Experience, and Bernie Owens, Director of Unscheduled and Acute Care. So you'll be familiar with the process. 10-minute presentation, then we'll open it up to members.
Thank you very much, Chairman. If you don't mind, I'll take up the 10 minutes in terms of the presentation. First of all, I welcome the opportunity to have a discussion today with the Health Committee, and thanks very much for inviting us here this afternoon. What I want to do is cover a number of areas very quickly. First of all, the context for the Trust, giving you some idea of the scale and size of the Trust. Highlight some of the quality indicators, because I think it's important that we give some assurance to the Committee in relation to the wider quality indicators that there are for the Trust in relation to its performance. Talk a wee bit about the reform programme that we have in place in the Trust, because it's relevant in the context of the changes that are happening. And finally, outline for you very quickly the ED journey that we've had over the last couple of years. But first of all, if I could just very quickly set the Trust in context. As you will probably know, we employ over 20,000 people. We're the largest employer in Northern Ireland, bar none in both the public and private sector. We have a turnover of about 1.3 billion. We see about 130,000 inpatients every year. We have over 800,000 outpatient attendances every year. We have 153,000, almost 154,000 emergency department attenders. We have almost 111,000 day case patients. We look after 669 children in care. We're the corporate parent for those children. We have 424 children on the Child Protection Register, and we provide almost 6,000 domiciliary care packages in relation to providing care in our local community. And just very quickly, Chairman, I've shared with you, I'm not sure if it was tabled with you today, our annual quality report, which was the annual quality report for 2013. And then I just want to highlight very, very quickly some of the indicators in that quality report as well. There are a number of measures which are used in hospitals across the world, and in fact in UK and Europe, to gauge the quality of care that might be provided in the hospital system. One of those is emergency readmission rates, in other words, the number of people who are readmitted to your system because the treatment may not have been optimum when they arrive. Belfast Trust readmission rates are lower than peer hospitals in GP. We have roughly about a 4.5% readmission rate compared to over 6% in other hospitals in the UK. I want to also mention infection control, because it's not that long ago we were in front of the committee as a group of trusts in relation to the infections and the level of infections in our hospital system. And again, it's a quality indicator in relation to the quality of care that's provided across our hospital system. We have dramatically reduced over the last 3 to 4 years infections, both in terms of C. difficile and MRSA. And in fact, this year, we're the only trust of the 5 in Northern Ireland that will be meeting our infection control targets. And our MRSA, we were 100 days free during this year across all our sites in terms of MRSA infection, which again was a big achievement for the staff and the organisation in terms of the ownership and commitment they have shown to ensure they provide that level of high-quality care. Mortality rates, probably people will be familiar with the Mid-Staffordshire issue in the past, where mortality rates are an indication of whether or not you provide good quality care as well. In Belfast, our mortality rates are lower than what would be expected for a hospital of our size and profile of services, and in fact are lower than a lot of our peers in UK and other parts in other hospitals in Europe as well. So we perform very well in terms of those mortality rates. Our critical care is world leading in relation again to the mortality rates that we have in our critical care system. And that's something that I think we should all in Northern Ireland be very proud of. In terms of our cardiac arrest rates are important in the context that if you continue to provide proper care to people, then they should not suffer a heart attack in your hospital because of the attention they receive. Our cardiac arrest rates have reduced very, very significantly over the last 2 to 3 years as well. So that's another very positive quality indicator. And finally, I want to mention the National Hip Fracture Database, which again, in terms of our hip fractures, indicates that our mortality rate and the death rate in relation to people who've had a hip replacement in Belfast is lowest of any in the UK again. So it compares very, very favourably in the context of those quality indicators overall. Very, very quickly again, Chairman, if you beg your indulgence, I want to turn to the reform programme over the last 2 or 3 years that we've put in place in Belfast. Some of you will be familiar with some of the changes that we've made. So, for example, we have a vision that we would have, as far as we can, one hospital on 4 sites, and that we would provide services which are local where possible, but centralised where we believe it's necessary. So people will be familiar with the changes that we made in obstetrics quite recently, where we actually centralised our obstetrics in the Royal Victoria Hospital site, which meant that the obstetrics that was in the Mater site was moved to the Royal Victoria Hospital site, but we ensured a midwifery-led unit was retained on the Mater site to provide local accessible services. What we have also done in relation to a range of our other services to ensure, as far as possible, that we have complementarity on one hospital on 4 sites. We've centralised our vascular services, our ENT services, our gynae surgical services, and we've also centralised our emergency surgery services on the Royal Victoria Hospital site. And I'll mention later again about the emergency surgical unit that we've introduced there that will help in terms of how we move patients through our emergency department. I want to turn then very quickly to the journey that I've mentioned in relation to our emergency departments over the last 2 to 3 years. In relation to, I'll start with the changes at Belfast City Hospital, because I think that's important to give a context to that as well. Members will remember that the driver for the change at Belfast City Hospital were the staffing issues. It was nothing to do with costs. It was nothing to do with downturning the number of staff that we had. It was, in fact, that we weren't able to recruit middle grade and senior decision-making staff in order to cover the ED at Belfast City Hospital. We were spread over 3 ED sites, and we just didn't have enough staff, nor were we able to recruit the staff to cover Belfast City Hospital. Whenever we made the changes, we transferred the staff from Belfast City Hospital to the Royal in the Mater. So we went from a complement of 6 consultants on the Royal site to a complement of 10. It meant we were able to rota our consultants instead of from 9 to 5, Monday to Friday, and Saturday and Sunday. We were able to rota them during the week from 9 to midnight. And we were also able to ensure that if you had gone into the Royal previously, you would have been seen potentially by a junior doctor. We have our senior trainees and middle grade staff actually covering from midnight to 8 a.m. in the morning. So we have senior decision makers who are actually there that will see you, whereas in the past we would have had junior staff who would have done that. Part of the impact and that has been over that period of time. When the city was open, we would have had about 1,700 people who waited for 12 hours or longer to get admission to our hospital system. We're now down to, and I'm not saying it's acceptable, but we're now down to just over 300 people who would wait longer than 12 hours just this year to get access to our hospital system, and we want to reduce that still further. We don't believe that's acceptable in terms of how we move forward. We've also put in place a number of changes which we believe, as part of the journey, will help in relation to the patient flow in our hospital. We've introduced an acute medical unit in the Royal Victoria Hospital site. We increased the number of beds from 28 to 61 a couple of years ago. We have direct access for GPs both on the Royal Victoria Hospital site and on the Belfast City Hospital site. We have a programme treatment unit within our ED, which is designed to ensure that people who come in with certain conditions are turned around very quickly without requiring admission directly into our ED. We have also given pathways. We have pathways into our specialties within the Royal Victoria Hospital, which does not require our patients, and the Belfast City Hospital, which do not require patients in some cases to go through an emergency department, all designed to reduce the pressure where we can. We also have rapid access for neurology now, which, if you can imagine, people who come into our ED who are suffering from headaches, etc., we now have rapid access, and our neurologists have agreed that those people will now bypass our AMU and go directly from our ED into neurology. We've also introduced a primary percutaneous cardiology intervention service.
Sorry, what does that mean, Colin?
Well, what that means is it's cardiological intervention where someone has a heart attack and requires a stent or requires a physical intervention. That has now centralised on the Royal Victoria Hospital site, and 75% of the people or the population in Northern Ireland, if someone has a heart attack, they go directly to the Royal Victoria Hospital site. That's working very well in terms of the numbers of people who are using that service and the numbers of people who are getting a very good outcome, a positive outcome in relation to that service. We've also introduced an emergency surgical unit, both an assessment and inpatient unit, so that again, people who come in with abdominal pain or potential surgical problems are seen very, very quickly and turned around quickly, rather than having to wait in a ED or rather than having to go in as an inpatient into our hospital system, when they can be turned around by our surgeons very quickly. I understand, Chairman, I'm probably using up more than my 10 minutes, but very quickly, just to try and finish it off. We do recognise that there are still challenges for us. We do recognise that there are other elements of the system that we still need to improve, particularly in terms of patient flow. What I've tried to outline to you is the level of reform and change that's taken place, and the fact that we're working very hard to ensure that that level of change and reform does end up for us actually improving exponentially the patient journey. So we are focusing very much on discharge as well. We recognise that in terms of the patient journey, it's not just about people who are coming through our front door in our emergency departments, but it's also about ensuring that we create capacity in our hospital system and that we have timely discharge in terms of that. So we have a very strong focus on that, and we have a project that's running currently. We're working with our Integrated Care Partnership in Belfast to put in place various schemes and proposals to try and manage the demand that's also coming into our hospital system. So we have an acute care at home pilot, which is running, led by one of our geriatricians together with general practitioners in our local community, looking at those frail elderly, maintaining them at home. People who might otherwise have required admission to our hospital system are being maintained at home through our acute care at home project. And there are other projects like that that we're looking at with our Integrated Care Partnership that we believe will also help start to manage some of the demand that's coming into our emergency department, as well as actually looking at how we manage the capacity in the hospital. And finally, we've shared with you the action plan from the College of Emergency Medicine. One of the key planks in the College of Emergency Medicine plan is 7-day working. And 7-day working is not just something for our emergency department, it's right across our hospital system. It's something which is not just new to Belfast, it's something which right across Europe, hospitals are struggling with how to introduce 7-day working. So what we are looking at within our ED, and we've quite recently been able to offer additional posts to ED consultants, we're looking at how we can equalise out, over the course of a 7-day week, the pressures that exhibit, because you will know, and the committee will know, that it's on a Monday and a Tuesday that we face most pressure, because it builds up over the weekend, because we don't have the same level of senior decision makers on over the weekend, nor do we run our elective care over the weekend either. So it tends to build up at the beginning of the week. So we're working with our Commissioner, and I know that in the commissioning plan, which our Commissioner has just approved, they have highlighted 7-day working as one of their priorities as well. Just at the moment, we wouldn't have the resource to do that currently, given that it would require additional consultant resource across a whole range of different specialties to make that happen in a short period of time. But our Commissioner has shown willing that that's a priority for them as well as the Trust. I'll leave it there, Chairman.
Okay, thank you, Colin. We've just heard from the Royal College of Nursing, and they've been very frank in indicating that the system is actually too focused on targets, and the targets have become more important than people. How would you address that concern?
Well, that would be something that we wouldn't find tolerable in our system, Chairman. Let me start off by saying that where a system or organisations are judged by performance against targets, sometimes that can skew behaviour. So if you're judged by how many 12-hour breaches you have, then sometimes you can skew behaviour in your hospital system. We are very keen in Belfast that it shouldn't and shouldn't skew behaviour. For us, what is primary in this is the care and the critical priority that is given, the clinical priority that is given to patients. So I can give you an example. Recently, when I was in the hospital in the ED, when one of our ED consultants came to me and said, we have a system called Symphony, which highlights all of the people who are waiting in our hospital system, and she indicated to me that she had given priority, clinical priority, to a patient to be admitted above another patient who had just breached 12 hours. And that was absolutely the right thing to do. So it wasn't, the 12-hour breach was not given the priority over the clinical condition that the doctor made the decision to admit. And decisions are made by our doctors and nurses in terms of admission and the priority that's actually given to people for admission. So they would not put the 12-hour target in front of a clinical priority.
So are we saying that under no circumstances, there are no circumstances where a patient would be moved from an ED, from an emergency department, in order not to breach a 12-hour target? That simply doesn't happen.
No. What I would say to you, and I suppose we need to be clear, the 12-hour target is a target because we know the evidence shows us that the longer someone waits on a trolley in an ED, potentially the poorer the outcome is for them. So that's the reason behind the target. That's the objective behind the target. So that people don't wait as long, only wait as long as they need to, so that they have a better outcome. That's what drives us in relation to that particular target as well. So what I would say to you is that whenever we are dealing with the care of patients, when we identify a solution for a patient who's waiting in our ED, we would be very keen that we move them to that solution as quickly as possible, and certainly before they're waiting for 12 hours. So the 12 hours does play a part, but it does not take precedence over clinical priority. Clinical priority would trump the 12-hour target all the time.
So there are no situations whereby a patient would be moved into a situation that would be either not safe or not sustainable?
No, we would not move patients into an unsafe environment. And I'll give you an example of that again, Chairman. Obviously, in the context of some of the recent instances that have happened, for example, on the evening that the major incident was called, part of the reason that we didn't have sufficient capacity in the hospital is because we couldn't open sufficient beds with the proper nursing skills to nurse the patients in the hospital system. And the only way we could get the proper skilled nurses onto the site was by triggering the major incident. The other thing to say to you is we had exhausted all of the agencies, we'd exhausted all of the bank nurses in terms of the skill of the nurses that were available. And while there were nurses available, they weren't of the skill that we required to look after patients when they were admitted. So it is not the case that we would admit patients into an unsafe environment.
Okay, can I ask you directly again, coming from the previous evidence session, that it was indicated that there are nurses working above their competency levels in emergency departments?
I'll ask Brenda to address that, but it wouldn't be our understanding that nurses are working above their competency levels, but I'll explain.
Thank you. I know that has also that was also raised with us with our QIA. We have over 90 nurses at the moment working in the Royal ED, and they are nurses who, some are recently qualified, others are very experienced. Part of our process for bringing in nurses is that they have a period of induction, and they will work alongside another more experienced nurse in areas such as triage or resus to gain those skills. Now, we have had some issues with sickness levels, for example, but it is the nurse in charge will allocate nurses on a shift-by-shift basis, supported dependent on their skills. Now, on occasions, if we have vacancies, if people are ill, for example, we will bring in bank and agency nurses, but they are always supervised by the nurses who are in the department. And that would be a great concern to me, and certainly we've done an awful lot of work with the emergency department to look at the skills of the staff in each area.
But you are saying it is happening because RQIA have...
RQIA raised it as a concern with us.
And it is obviously of a concern.
It would be a huge concern because nurses need to to be trained in the area of expertise. Obviously, nurses, when they graduate, have a degree of expertise and they have half of their clinical time with us whenever they're at university. But in a specialist area such as the emergency department, they need to have more on-the-job support, which we provide for them.
But there's ultimately, if there's a concern and there's anybody in any walk of life that's working above their competency levels, then is there not a risk to safety?
Yes, there would be a risk, and that's why we have the processes in place we do. And certainly it would be my expectation that the nurse in charge of the department would allocate nurses dependent on their level of skill.
But sorry, and maybe I'm not framing this properly, but it's been flagged up. It is of concern. Do we wait for the outcome of the RKA report, or what? It's still happening?
No, we don't wait for the outcome. In fact, we have had, we've done a number of pieces of work with regard to the emergency department staffing levels, which started several years ago whenever we made the move to the Royal and the Mater sites. We reviewed the skill mix then. We reviewed the skill mix again in October of this year, and we were in a period of recruitment to bring in more nursing staff into the emergency department. Where it does become an issue is if we have vacancies or if we have higher levels of bank and agency nurses than we would like, and certainly staff do need to be supervised in areas. And I mean, you've seen the way the emergency department is laid out. There are areas of higher risk, and the two key areas of higher risk for us are triage and resuscitation. And certainly, in the normal course of events, nurses would expect to have a certain lead-in before they work in those areas, and that's what happens in the emergency department.
Yeah, but ultimately, as of today, as of we are sitting here at this current point in time, a risk that is a risk is still in the system. We haven't removed that issue.
Chairman, the question you're asking is, do we have nurses currently working above their competency levels in our ED at this time?
Yes.
Yeah.
And we do. And there's therefore a risk.
Well, I would say that the nurses are being supervised, those who have less experience than others, and we allocate nurses dependent on their experience. And it's the role of the nurse in charge to mitigate those risks. We do have a lot of new staff who have been starting with us since the beginning of the year, and certainly they're working in a supervised capacity. And whenever the risk was raised with us, with RQIA, initially we had a 2-week off-the-job induction followed by a 2-week on-the-job induction. We've now increased that to 6 weeks on the basis of those preliminary recommendations.
Okay, just in relation to the recent deaths, subject or not to potentially being linked with undue delays in terms of serious adverse incidents, why did the Trust not inform the Minister, if that is accurate?
Well, I'll ask Dr. Stevens to fill in some of the detail, Chairman, but just to say to you that to give you some background and context to serious adverse incidents, in any hospital system, what's important for us, and every serious adverse incident is a human tragedy, and is something that we don't take lightly, and something we don't want to see happening. What we're very keen on is when we do have a serious adverse incident, that first of all it's highlighted, because we need to learn the lessons from a serious adverse incident. And throughout the world, again, and hospitals throughout the world, and in America quite recently, led by the IHI in Boston, the Institute of Health Improvement, the campaign to save 100,000 lives was predicated on the basis that there were about 1 million people in the American hospital system who were either having serious harm or dying because of mistakes and errors in the hospital system. And therefore they set out to save 100,000 lives by introducing safety bundles, which we've introduced in Belfast as well, to save those lives. So the reason I'm telling you that is to say that each one of those incidents is a tragedy. What's important for us is to learn from them, and so that, and we want to encourage our staff to continue to highlight them. Serious adverse incidents are raised by us. They're investigated within our hospital system, and it's important that we continue to encourage staff to do that. Last year we would have had 93 serious adverse incidents in our hospital system. We share that we have a governance arrangement within our organisation where we learn from those serious adverse incidents as we take the learning from them, and that's shared within the system, the wider health and social care system as well, in terms of the learning that comes from that regionally. So in relation to why was the Minister not told, it is the case that there is a governance assurance framework in place, an appropriate escalation for the SII process within our system. So it wouldn't be the case that there would be an obligation or a requirement to indicate on every SII or individual SII to the Minister what has happened or what is the circumstances behind each SII. So I'm not sure if that's answering your question.
You see, I suppose in terms of accountability and governance, it brings up its own questions, because ultimately it's the Minister and the department, and why the Minister of any department would find out about serious adverse incidents through the media leaves us all raising the question. So it doesn't really answer my question, and I suppose the follow-on to that is that why were the families of these individuals not informed?
Okay, I'll answer that, and then I'll ask Dr Stevens if he can give you some more background on the SAI process itself. First of all, it is entirely unacceptable to me and to the Trust that families weren't informed. It is an integral part of our policy that families should be involved and should be engaged. In these particular instances, they weren't. In the vast majority of SIIs, they have been. In these particular instances, they weren't. And we're looking into that in our organisation, investigating that very thoroughly as to why families weren't informed in these cases, because it is a part of our policy that they should be informed.
Well, on that issue, just finally on this particular issue, why call a review now? Why is there a review in the serious adverse incidents now? If there has been learning that has been shared right throughout the 93 cases, and why now? Well,
I'll ask Dr Stevens to answer, but there is constant learning from SIIs. It's an ongoing process. Every SII is taken forward in the context of the learning that we can get from it. We have an SII review board which is chaired by our Director of Nursing, Brenda, here, in relation to the learning right across the Trust. So if an SII happens in one area of the Trust, what is the learning that we can have from that across the Trust? And more importantly, because the SII is also monitored by the Health and Social Care Board, there's learning then that can be proffered across the entire system from individual SIIs. So it's not that we keep SII secret or we keep them. We actually share that learning right across the health and social care system. We're very transparent across the system about the SIIs. The families should have been involved in those particular SIIs, and they weren't, and we're looking at why that was the case.
Okay, on a separate note, and I know there's a number of people are looking to come in terms of recruitment. Now, the Minister's recent statement had talked about the recent recruitment drive for emergency departments, but that there was no applicants at middle grade. Why is that?
Well, again, I'll ask maybe Dr Stevens will be more conversant with the detail, but it has been it's a problem right across UK and Ireland in terms of middle grade, the availability of middle grade doctors. It was the primary reason that the changes happened at Belfast City Hospital. There just isn't people choosing to be middle grade as a career grade in emergency departments right across hospital systems across the UK and Ireland. There just isn't the availability of people. It isn't that we haven't attempted to recruit, because we have. It's the fact that people aren't choosing that as a career option. Maybe Dr Stevens could elaborate a wee bit more for you.
Yes, Chairman. I suppose that we need to define the middle grade. We in the health service talk about consultants as our senior doctors, and then we talk about our junior doctors, and by really in this context we're talking about the younger doctors who are at houseman or what we used to call SHO level. And then we have a group of people who are in specialty training. They're training to become specialists and then consultants. And we also have people who choose a career in a certain area, maybe won't go on to become a consultant, but become very, very experienced We normally call those specialty doctors or associate specialists. So the middle grade is made up of people, the more senior trainees, and people who've made a decision to have a career in a specific area but below a consultant level. So it's a very important group. The reality for us is in both the senior trainees and those who've chosen a career just below consultant grade, it is very difficult to recruit. They don't. The people who are looking for that career position are not looking for it in emergency departments. There are more attractive specialties for those people to work in, particularly because of the hours and the demands. For the trainees, across the senior trainees, there are just not enough people in the United Kingdom, or indeed other parts of Europe, and including Ireland, where people want to work trained to become specialists in emergency medicine. So we're fishing in the same pond as every other trust in the UK. And Belfast, in many ways, does quite well, but not quite well enough. So, for example, on the senior trainees, we're allocated, and they're allocated to us. We don't recruit our trainees. We're allocated 7 registrars to work in the Royal, and that is barely enough for us. We really need more of those, but they really don't exist, partly because it's a scarce resource that has to be shared out with the other trusts. Although the Belfast Trust has a particular challenge in that the General Medical Council, indeed the Deanery, require us to have somebody at a special senior trainee level, middle grade level or consultant level in the department 24 hours a day. We're the only department really that is obliged to that, and that reflects the regional nature of the Belfast Trust, and in particular the Royal and its role as the trauma centre. So we are handed, if you like, a manpower situation that actually we can't actually change. We can't actually increase the number of senior trainees we have, not because they don't exist and they're allocated. And on the middle grade group, the other middle grade group, these people who are seeking a career in the emergency department below consultant level, they don't exist.
But is it not suffice to say that it's not an attractive career because the system's so under pressure, particularly in terms of emergency care, that people are voting with their feet and not applying?
Well, that is absolutely true. You have to understand a whole lot of issues across the UK. It is a very demanding area to work. We're dealing with a reality that medicine is now predominantly a profession of women. 60–70% of people coming out of university now are women, and they are making choices that take them into other specialties. So I can list for you the specialties that are very popular and the ones that are less popular, and that is an international problem.
Yeah, but if we know that and we've identified that, it leads me on to issues like contracts. When we visited the Royal on Monday, we were told that, that the trust could be more creative in terms of contracts. When we look at workforce planning, when we look at all of those issues that come alongside it. So what have the trusts done? If we've identified that that's an issue and that the trust have control of it, what has the trust done?
Well, I think there's two things. The first creative thing that we're doing, which is to look for alternatives to doctors, and we are now the first trust to start training nurses as advanced nurse practitioners. That is a genuinely creative move, but it will take us another year or two to have those people fully functioning. That's part of the solution. The other issue for us is that we've been creative in arranging for general practitioners to work in our emergency department in the evenings. But again, that is a very scarce resource, but it is helpful to us. So they come in and help take some of the patients, see some of the patients who are more suited to a general practice rather than an emergency department. We've advertised very heavily for middle grades, and I think we've also accepted that if we cannot recruit middle grades, and if that's a truly international problem, then let's not expend all our energy on that. Let's accept that we may have to recruit more consultants. We have done that. And we will continue to do that. We're in discussion with the Health and Social Care Board now, I think, positively. There's a positive recognition that we'll have to expand the number of consultants working in our emergency departments and accept that actually, for the emergency departments to really thrive, it is going to not only have to be a service led by consultants, but also in large measure delivered by consultants rather than doctors in training and rather than middle-grade doctors.
Can I just say, Chairman, you'll be aware that the consultant contract, is a national contract. And in regard to, there's ongoing negotiations, again, in relation to the GP contract and the consultant contract in relation to what that might look like in future. But within that nationally agreed contract, there are, if you like, there is flexibility about how we actually negotiate with our consultants in terms. So I'll ask Bernie to actually outline to you some of what we're doing. For example, each consultant has an individual job plan, but there is also a process within the contract that we can annualise those job plans so that we make the best use of our consultant workforce in terms of that.
But ultimately, the Trust has the control in terms and conditions of contracts.
No,
there's a flexibility. You just said.
There's a flexibility about how we can apply that in relation to, for example, the job planning and team or annualised job planning, which gives us a bit more flexibility. But the national contract is quite.
Yeah, but without getting into the detail with respect, I mean, I'm suggesting that if it's been flagged up as an issue in terms of recruitment, obstacles to recruitment, people viewing work within the emergency care department as under pressure, as stressful work, as people are not applying. We've seen the recruitment drive, no middle grade doctors apply. So, and what I'm trying to get out, not getting into the details of negotiating out contracts, the Trust have a degree of flexibility. Why would it not have happened before now if we know it's an issue?
Could I maybe just make a very quick point here? We do have national terms and conditions. So our flexibility isn't as great as you might think. And the other thing is that if we as one trust were to waive those terms and conditions very substantially and make a very generous offer, all we will do is steal the competent and able doctors from other trusts. So we might please the people of Belfast, but we will seriously inconvenience those in Craigavon or out in the Galvin or elsewhere. So we do have to be fair, and we expect the other trusts in Northern Ireland to be fair and try not to really go too far outside of terms and conditions. The reality is that there aren't enough trained and competent people there for us to recruit. We don't determine the number of people who come into training. That is not the Trust's responsibility. We can't make the specialty more attractive to young doctors who want to train as opposed to going into anaesthetics or general practice or surgery. That is not our role or function. All we can do is make our jobs as attractive as possible. And if we do that, and if we really broke the terms and conditions substantially, you would find howls of protest from the other trusts in Northern Ireland.
But this isn't, sorry folks, this came from your own doctors. This was recommendations that came from your own doctors about being innovative and creative with contracts.
Bernie's in discussion with our ED consultants at the moment, for example, around an annualised job plan, which actually is very positive with both there.
And it's not, sorry, not to cut across, Colin, but it's not about money.
No. And that's,
this is about, sustainable workforce planning and other opportunities that go alongside it, particularly within stressful scenarios like emergency departments.
And that within individual job plans, we make sure that there isn't a balance for every consultant job plan that gives them the period that they work and also periods when they have protected time away from the workplace. Our consultant workforce is seeking to have their job annualised so that they can have some flexibility within that, and some weeks it might be more onerous and some that are less onerous. And we have agreed a way forward with the consultants, and we are putting in place with their agreement and subject to them signing that from the beginning of April.
Okay, thank you for that. Fergus, next.
Thank you very much, Chair. Can I just start? Did you hear the submission, the actual submission this afternoon from RCN?
No.
But it might be fair then just to repeat some of the remarks that were made. And they've talked about the plan that you're working on in terms of basing it on in terms of TYC, for example, as a vision without action. They've said that the change agenda is neither open or transparent. They've said enough is enough. They've asked where is the patient in all of this. They say the system's neither effective or efficient. They've said, described things as not being fit for purpose. They're seriously concerned about targets over people and the system supporting bureaucracy, not patient. I wonder, could you contrast with me those remarks with your opening remarks where you refer simply to challenges ahead, for example, around patient flows?
Well, I would have to say I'm disappointed to hear that that was part of the submission you received earlier today. We work very, very closely with the RCN and with our trade union side and staff side colleagues in a partnership arrangement, which I think is a very positive arrangement that we have with those organisations. RCN, we've had many discussions and engagements with them, and RCN have raised issues with us, which we've addressed with them at the time. I mean, how I would compare what you've just outlined to me to what I said is in complete contrast. There's a pretty stark contrast to what I've said to you, Fergal. So, I mean, and therefore, there's a judgment here in relation to, you know, well, I mean, when they say the system isn't open and transparent, what I would have to say to you is I would accept that we still have a journey to go to be as open and transparent as we possibly could be. But I do believe that we are as open and transparent as many other healthcare organisations across these islands.
Yeah, but in fairness to them, I think they're talking about outcomes. And while yes, I agree, there's a judgment to be made here. In this case, it's not a fine judgment. There's a yawning gap between the frontline nurses' perspective of the service that's been provided for patients and yours. And what do you put that down to?
Well, what I would say to you is, and you'll be familiar with the RQIA preliminary feedback that we received quite recently in relation to ED and AMU. And I was very disappointed, I have to say, as were the Trust Board very disappointed with the feedback we received. And what we immediately did on the back of that was to put in a support group into both ED and AMU to look to see if there was that chasm that you're identifying, Fergal, in relation to people's views on the ground and what we believe as senior management was happening. And in that support group that we put in there, it was occupational health, psychology, senior nurse and senior HR practitioner to actually help staff in relation to the clinics that we ran within our ED and AMU. And can I say to you, in terms of that very disappointing feedback, what the feedback we received from those clinics, and there were over 50-60 staff that availed of the opportunity to speak in those clinics in an anonymous way, so it wasn't that the staff were identified. And the feedback from that, from staff to us, was that they were feeling under tremendous pressure at times, that they were working in a very pressurised system, and they felt that they weren't necessarily given the support that they should be given. So what we've immediately moved to do is to put in place the supports that were identified to us from staff at that time, in order to ensure that they are provided with the necessary support. So we've introduced things like team briefs every day. It might sound very simple, but again, in terms of the effective communication, some of what happens in the midst of the change that's going on, and some of it is quite radical and transformational, is that the communication that needs to happen to keep staff informed and up to date with the direction of travel and the overall objective of the change sometimes gets lost. And we believe that was the case in this particular instance. And in fact, now we're putting in place, and we've moved very rapidly to put in place, the changes that we hope will then bridge that gap of understanding between what I've just outlined to you in terms of the direction of travel and how we get there, and ensuring the staff are properly supported to deliver that change.
But notwithstanding what you're saying about the systems that you're putting in place 2.5 years after the introduction of a major change platform, there are still huge gaps, it seems, at least on the basis of the evidence here today, between those who are at the front line and those who are in that change of travel. Can I just turn to the policy around A&Es from a departmental perspective and how it applies to you? Is Transforming Your Care clear on the policy direction for A&Es?
Well, it's pretty clear on the direction for the 5 acute hospital networks that's identified, and for Belfast. that actually means that we have one hospital network in Belfast. What it wasn't specific about, and I think it's right that it wasn't, is how we manage that particular network. So how many EDs should you have in Belfast, or how many should you have elsewhere? So TYC, or Transforming Your Care, was not specific about the numbers of EDs that should exist as a part of the hospital network, but it's for the hospital network, along with our stakeholders who are our local communities and our politicians and others, to determine what the future looks like in terms of our acute services. In Belfast, as you'll understand, the changes that were made at Belfast City Hospital at this point in time are still changes that have not been finally, if you like, decided upon in the context of the final configuration. But it is our view in Belfast of what that configuration should look like for the future for EDs in Belfast, that we should have 2 front doors in Belfast, one in the Mater and one in the Royal Victoria Hospital.
So the situation that we have at the moment isn't satisfactory, either with policy or structurally?
No, I wouldn't say that. I would say that the situation we have at the moment in terms of the policy is that there's a clear direction of policy, but how we get there is entirely up to the system in terms of the delivery and the optimum delivery of care for patients in the system. If I maybe explain it in another way, what we as providers are most involved with, if you imagine that in a commissioning providing system, the most important part of it, in my view, of the commissioning providing system is that you have a commissioner who's very clear about the outcomes that they would want as a part of the system. They're clear about the standards that you want to deliver care to, and they're clear about the funding that's available to you. We as an organisation then are responsible for the how. So we engage with our stakeholders, who are our staff, and also our stakeholders in terms of our GP colleagues in the community and other community providers in voluntary and community sector, about what it is we can do and how it is we can design a model of care that will deliver the outcomes within the money and the standards that's available.
Obviously, we're seeing it as pressure right now. We've always viewed this, from our party's perspective, as a symptom and not a cause, and therefore influencing the demand and however that could be done, community, etc., etc., etc. But if you took, and you articulated at the start, 159,000 ED patients, if you took the 59,000 out of that, because it's accepted at some 30%, and that figure's disputed up or down, whatever. But if you took that out, how much would that influence your need for middle-grade doctors or your need for emergency nurses if you were to remove, say, a figure of 60,000 off the 160,000 that you're presently looking at?
Well, it would have an impact, and that's why, in terms of, for example, the Transforming Your Care, the drive is to reduce the reliance on hospital systems and more on, for example, the acute care of the elderly pilot that I mentioned to you, which is led by one of our geriatricians. The purpose behind that is to ensure that people who would otherwise have had to come in, frail elderly people who would have otherwise had to come in to our ED for admission, are prevented from having to do so. So it reduces, that's the demand management part.
So when did you introduce the pilot?
It was, it's a while ago now. It's about 6 months ago, 7 months ago.
And why was the pilot not foreseen at the start of TYC?
And what, I'm not
sure. In the sense that if this had been, in terms of transferring the care, we've talked in very simple mathematical terms. I assume that somewhere at the start of this process, somebody must have done a back of an envelope at least calculation, which is saying, well, if we're going to move to community care, we roughly want to take the 30% out. So when you did that, did you not? Why are we waiting 2.5 years for a pilot to deal with something that we should have foreseen at the start?
Well, okay, I'll ask Dr. Stevens, because he's more familiar with the detail of the pilot as well and its gestation.
No, I'm not so much interested in the pilot and its specifics. I'm talking about the thinking behind.
Well, can I say to you, I mean, a lot of the concepts and principles in TYC, or Transforming Your Care, aren't new, and care in the community isn't new. Some people might remember the policy that was introduced in the mid-90s called People First, which was actually about driving and ensuring that we put in sufficient community infrastructure in place to ensure that we had the opportunity to deliver care closer to people's own homes and in own homes. The Transforming Your Care takes that just one stage further in relation to looking at that vis-à-vis the hospital system and reducing the demand and the need for admissions into the hospital system by ensuring that people are appropriately treated closer to their own home. I think your question is, transforming your care was introduced, you're saying 2.5 years ago, so why did it take 2.5 years for the pilot to be in place?
Yep.
I'll ask Tony to comment on this, but there was a process going through. You may say it's been too slow, but there has been a process that's been put in place. For example, as a part of transforming your care, it was identified that integrated care partnerships are an integral vehicle in actually helping deliver things like acute care at home. It took a period of time to set up the integrated care partnerships, which were driven from the Health and Social Care Board perspective, and it's taken a time for those integrated care partnerships to bed down in terms of the work that they're doing. But now the proposals are coming forward, both from ourselves and the integrated care partnership, which again is a virtual provider, so it's in the providing arena as opposed to the commissioning arena, and we're working very, very closely with them to redesign, and acute care at home is one of the redesigned models, to redesign services that will actually have an impact and reduce potentially the need for hospital admission. But I'll ask Tony maybe if he's anything.
Fergal, I mean, Colin's covered it very well. I think the thing for us is we were running issues in parallel. So the pilot, we were very lucky to recruit a community geriatrician who came from England with a huge experience of developing, if you like, the hospital at home model. And we did the pilot just to try and demonstrate how that would work. We're in the business now of actually moving more of our care of the elderly resource out of hospital into the community resources. But at the same time, we're working regionally through TYC, through the Health and Social Care Board on the integrated care partnerships, because the key thing of the integrated care partnership is it's a partnership of providers. So if the trust is only one provider, community pharmacy, general practice are the other key partners. So the exciting thing that's coming up now are that these frail elderly ICPs or integrated care partnerships that truly are a partnership between primary care and community pharmacy and others. So while the Trust might have been piloting things that we could do within our own resources to shift things, the partnerships are the key, because that gets us and the GPs in particular together. So the thing for us is, and I think one of the challenges in Northern Ireland has always been that we've had integrated health and social care, but we've never had integrated primary and secondary care. Just as the rest of the UK hasn't got it, we haven't got it. And the issue for us is about that key piece. So the exciting thing that we're starting the conversations about with primary care now is how, between our resource and primary care's resource, can we look after people in nursing homes and residential homes better, because they represent about 2% of our total take-in, and that may not sound like a lot, but that's 2% of our 100 people we admit roughly a day. So that if we can keep those 2 frail elderly people out of hospital every day, 700 people a year for us, that's a huge amount of resource. So that's the focus now. One of our focuses, the work with primary care. So that I think is taking a little bit of time to get off the ground, partly because we're bringing together this completely new invention, which is an integration of primary and secondary care plus the other partners.
Have you done any assessment on the impact transforming your care is having on the service overall, and what systems or measurements are you putting in place?
Well, we're not putting in a system or measurement for overall for transforming your care. What we have within our organisation is a very close focus on the areas that we're putting in place that will have an impact, which are consistent with transforming your care, and those will be individually evaluated in terms of, so for example, that pilot that I've mentioned to you in terms of acute care at home, that will be thoroughly evaluated, because we're now in discussions with our Commissioner in relation to rolling that out right across the Trust. It only exists in Meadowlands and in South Belfast at the minute. We want to roll it out right across the Trust in terms of the benefit that will have for frail elderly right across the Trust. But that will only be done on the basis of a thorough evaluation of the benefits of the pilot.
Okay, I'm not cutting out, but I want to move it on, because I know there's quite a number of people as well, Fergal, if you don't mind, that have indicated, and there's a lot to get through, and not stifling debate, but we need to give everybody an opportunity here. David, next.
Thanks very much, Chair, and thank you, folks, for your presentation. Just a couple of reasonably short questions, and you'll be glad to hear this, Chair. Transforming your care, I mean, if we were moving to the full implementation of transforming your care, and we could sort of jump forward and find ourselves in that place. To what extent would that alleviate the problems that we're currently having within our emergency departments?
It wouldn't fully alleviate them, David. What it would do is take pressure off attendances in our emergency departments and in the areas I've mentioned, particularly frail elderly, and there's a number of others, diabetes, stroke, etc. It would reduce the need for some admissions, but it doesn't negate the need for further work to be done on the patient flow system within the hospital itself in terms of how we make that even more effective, particularly at the back door in terms of discharge and ensuring that our discharge systems work really well in relation to the capacity in the hospital system. So yes, it is a factor and it would have an impact, but it wouldn't fully alleviate the pressures in the hospital system.
Okay. And then on a completely unrelated matter, and this was something that I did question the Minister about whenever he came to speak to the committee after the major incidents that had occurred. In relation to the distribution of information when it comes to these incidents, I suppose to contextualise, I mean, the sort of perverse nature of intellectually redundant journalism, of which we have quite a lot of in Northern Ireland, is that it can actually make very intelligent people look quite inept, and therefore, I suppose the need for, I suppose, a disciplined approach to how the media is dealt with and how that approach is taken, I think is probably necessary, because there clearly on the morning after the night before was a lot of confusion around even how many people potentially had lost their lives as a result of delays and so on, and I think that did send out a very worrying message. I'm not laying the blame solely of that at the Trust, of course, and you know, we all know how irresponsible the media can be, but what lessons have been learned from that? I mean, is there going to be a change within the Trust as to how disciplined they are around distribution of information?
Yeah, and lessons have been learned from that, David. And I think it's ironic that, in fact, what we were trying to be as a Trust, as we received the information, was being open and transparent. And the openness and transparency was translated into a big stick to beat us with in the context of being open and transparent. I'm not blaming the media for that, because that's the news is news for them whenever they receive that sort of information. But in an effort to be transparent, and the issue you relate to in particular, I think, was on the morning after the Spotlight programme. It was identified that there were 5 SAIs and not 4. Probably the mistake I made in the Spotlight programme was, while I knew there were 4 SAIs, I wasn't sure of the timescale, and while I did say I didn't have the information in front of me, I shouldn't have given a timescale when I wasn't sure of the timescale. So that did lead to miscommunication, and as you said, allowed me, potentially, and the organisation...
by the way.
I know it wasn't, David, it wasn't, to be portrayed in a light that we didn't know, or we weren't sure, or that we weren't fully conversant with the information. And I think that was unfortunate. And I think Dr. Stevens's interview the next day, where he identified 5, was the case that we'd had a conversation, and we if that is the case, then and we have identified 5, we can't say that there aren't 5, and we need to be open and honest about that information. But you're quite right, we've learned from that in the context not to be less transparent, but to manage that information flow in a much more effective way.
Thank you. Thanks, Chair.
Thank you. Okay, Gordon.
Thanks very much, Chair, and thank you very much, team, for coming in today. Just one question to start off. We are moving towards an independent review of the whole ED within the Royal. How do you see this review? Do you see it as an opportunity, or do you see it as just another review taking place?
No, I see this very much as an opportunity. I think this is an improvement process. And while the terms of reference have identified there will be a focus on the Royal, they will also be looking at the system across Northern Ireland in terms of emergency care, and recommending changes and improvements that can be applied across our system. So I see this very, very much as a learning process, and any improvements that we haven't thought of, or that the review team can come up with and help us with, we would be very keen to take that help and support.
Okay. Just going back there to our visit then we had on Monday, which I think we should extend thanks to all the staff and to everyone that took time to show us around. I think those of us that went along, in relation to the A&E, it certainly is a very busy place. We came away quite assured that there are competent staff there that know what they're doing and certainly give you a good feeling, and there's strong commitment to what they were doing, and that certainly did come across. But the building itself is, you're spread out in various sizes of units. We move from one to the other, and various treatments take place there, which to me it's not a great building, but I understand a new building's underway, and I think that's going to be very positive. The waiting room is very poor, and the waiting facilities, I think we're somewhat shocked. There are about 50 seats in there. So for the A&E, for such a major regional centre, and that's what it is, a regional centre in Northern Ireland, to have that is substandard. I think it needs to be addressed even in the short term. There was no information given up on screens as to waiting times. Now, I know there are pros and cons about that, but I was looking at that. The other thing which somewhat shocked me, 2 boos for triage, only 2 boos and 50 people sitting outside, so that's a bottleneck. And I know and I understand there's another facility used where the ambulances come in, so you've probably about 3, but still it does seem somewhat limited. We did see consultants and doctors available and so on. I would accept that. But what struck me was the consultants, talking to them, they feel that the workload is generally predictable in A&Es. Now, I didn't feel that was the case, but I came away understanding that is the case. It is predictable, even at the weekends and all the rest. And the points were well made by Brendan and others, that the weekends are the time when the rest of us are slowing down. And some of the MLAs don't agree, but the slowdown at the weekends, that's when he moves up a gear. Friday, Saturday, Sunday and Monday. So that's something that needs to be thought about in relation to 24-hour working. But the bottleneck, yes, we went then to 7B and 7C, and I think that really struck me as 2 very busy wards with, I understand, 60 beds, 30 in each, and a very busy place, somewhere that I think needs attention. The consultant fellow there, the new fellow, is it Mark?
Yes. Mark Roberts, yeah.
Yeah, Mark talked about 32 patients, I believe, have to move out of there every day to make the system work. Now, that's a real challenge. Now, that is difficult. That's half the people going in and out.
That's right.
So, you have so many people coming in through A&E, and as I understand, most of them are admitted then through those 2 admissions wards. So there's a major workload going on in there, and I think that's a real bottleneck, needs to be addressed. So my bottom line, without ranting on, is what is senior management doing? I know there's a review underway, but look, the senior managers are there. It's a huge organisation, 20,000 people. And we talked to Brenda about communications within the organisation. It worries me about communication. You are accredited under IIP. One of the things is engaging and empowering the workforce, recognising and continuously improving performance. Those are key factors. You've met those requirements on the standard. You're flowing about it within this report. It's not a bad thing to do, but you know there are weaknesses, and the public are aware of them. The media latches onto them. How can senior management move this forward on those issues without having to wait for someone from across the water or elsewhere to come
and can I say to you, we're not waiting, and we are moving on those issues. And I want to just touch, you said we were blown about IIP, but I want to do a wee bit more information around that. You may know that in terms of the Investor in People Award, it's across the organisation. It's not just confined to ED or the acute medical unit that you visited. And what happens, and we've just been reaccredited back in November, 8 inspectors come into our organisation over a 2 to 3 week period. They pick 800 staff in our organisation. They do it at random. We don't identify the staff to them. They do it at random, and they interview those staff in detail around the organisation. And we got a very positive report from the Investors in People inspection in relation to our organisation and staff engagement and how we engage with them. That's why it's even more disappointing when we get the feedback that we have in relation to our ED and AMU, which was why we've moved very, very quickly to put in place the engagement processes that I outlined to Fergal earlier on. And we are moving. The 7 B and C that you talked about is what we call our acute medical unit, and that is one of the areas that we're concentrating on. Part of the principle of the acute medical unit is that it's just that people should be there for no longer than 2 midnights, should be there for 48 hours, assessed, and then move on, if they need, to the specialty where they will get their treatment, or discharged in terms of the treatment they've received in AMU. So it is always going to be a very dynamic environment in terms of people moving through quickly, and that's the way we want it, but we need to ensure in doing that we support staff properly. But I'll ask probably all 3 who are here to outline to you some of the changes that we're making in relation to the acute medical unit, including the recruitment of additional staff, but not only that, the process changes in relation to rapid access to other specialties, etc., that bypass AMU to ensure that people are supported properly.
And I just, sorry, we're thinking I'm stopping you, Brenda, but we're getting into the operational issues as well, and I do think a lot of that's reflected in the briefing paper that you've supplied for us, so I'm just conscious of giving everybody the opportunity to have their direct questions. So if I can move it on at this point, and we're quite willing to re-engage on these issues. I have...
Right, Chair, can we not...
Sorry, Gordon.
Yeah, just get me some answers briefly on those issues, please.
Well, okay, I'll do it very, very quickly. In terms of the acute medical unit, we've recruited 25 additional nurses, and that recruitment process didn't start just in the last month or so. It's been ongoing for a period of time, when we constantly carry out review on our staffing levels within each of our areas. It's fair to say that as a result of RQIA, we increased that, the RQIA inspection, we increased that again, but we were already recruiting additional nurses.
Sorry, that's
prior to that.
The admissions wards?
Yes.
That's it. That's the acute medical unit, the 25 additional staff there. We're also ensuring that only those people who need to go to the acute medical unit go to the acute medical unit. So we're in discussions with specialties in other parts of the hospital, like neurology and cardiology, that people get direct access to those specialist areas directly from ED, rather than having to go through the acute medical unit, so that it's really the people who require to go to the acute medical unit that go to the acute medical unit. So those patient flows have been worked on very, very closely. The emergency surgical unit that we have in place is also designed to ensure that people who have surgical issues get direct access to our emergency surgical unit, rather than going through our acute medical unit again, so that they are dealt with in a way which is both in a high quality way, but in quickly, so that they're turned around much more quickly than they would have been had they gone through the medical system. If you like, maybe there's other...
Could I just say, going back to why the acute medical unit is there in the first place, because we haven't always had it, and that has been a development that we have had going back to 2012. It was one of the areas that we had sometime shortly after the Belfast City Hospital emergency departments closed, was an issue for us that we still had a sizable number of beds that we needed to access on the City Hospital site for patient care, and patients were being transferred over for specialist intervention to the Belfast City Hospital. But rather than having patients waiting in the emergency department to be transferred over to the city, that we had to have where acute physicians could assess those patients and start their treatment plan of care before they were transferred on to the specialist, and therefore having a safer journey for patients. And we then resourced the acute medical unit from the point of view of making sure that senior medical staff were available and were seeing the patients on a timely basis and assessing and starting that care. So that's why we still, from a medical point of view, have the patients are going through the acute medical unit. But as Colin has said, one of the focuses we are now looking at is having an assessment area where, and we have changed the acute medical team actually coming more into the emergency department, and seeing the patients, assessing the patients earlier in the journey, than even so they don't all have to go to the acute medical unit if they've been seen by the acute physician in the emergency department, and get to the right specialist team first time.
Okay. Thanks very much, folks. Thanks, Chair.
Roy?
Again, thanks for your presentation. I want to go back to the issue of the shortage of the middle grade NE doctors. And that was given as the main reason for the closure of the Belfast City Hospital and indeed a number of other units. Why is it only recently that you've announced this issue of training to advanced nurse practitioners? Why did something not happen 2 or 3 years ago?
Well, it did. Well, maybe.
Can I'll
ask
answer. The advanced nurse practitioner is a new role, and we have 2 people, one of whom you may have met actually on Monday, in training. It actually takes 4 years in total to train it.
So when did you start to train these new nurse practitioners?
1 2 years ago and 1 year ago.
Okay.
ENPs as well, emergency nurse.
Yeah, we also have emergency nurse practitioners who, you'll recall when you went into the department, there were the minor and the major stream, and the emergency nurse practitioners are those who work with the more minor injuries, and that's a very rapid turnaround. And we have almost 6 emergency nurse practitioners who run that area and manage minor injuries.
Maybe just to say to you as well that training isn't available in Northern Ireland. We have to send those nurses elsewhere to be trained.
And can I compliment that service? You know, I was actually in and out of White Abbey Hospital in 25 minutes, having my shoulder x-rayed and been given a sling appropriately. So that service can work very, very well if it is a minor injury. In terms of the Royal, the RCN have indicated to us that they think about the accident emergency staff, the nurses, about only 50 to 60% of the staff are permanent staff who are there regularly as a team. What do you say to that, Leanne?
That's not the case. We have had some vacancies in the emergency department, but in the past year, from April last year, we've recruited 18 new staff nurses into the emergency department as part of our ongoing recruitment, and we've also recruited 6 deputy sisters into the department. Our figures.
Percentage would have been?
Our total number of staff, actually, for our core staff, not including the emergency nurse practitioners, at the moment is 87 and a half staff. Now we're in the process of increasing that up to 100 staff. As we stand at the moment, well, we had 10 vacancies. We've now appointed into those positions. One of the greater issues for us in nursing generally is because, similar to medical profession, it's a largely female-oriented profession, and it's good news. We have a number of people who take maternity leave, which is roughly about 5% of our workforce at any given time. And in this year, we've had 3 people. Well, between 3 and 5 people who've been on maternity leave. So we do replace those.
What percentage of the staff would be bank staff? Maybe your employees, but what percentage are bank staff that are not normally rotated in there, like permanent staff?
Yeah, it's variable. It depends on the
Give me a figure.
amount of absence. Yes, it would be between. I can give you the actual numbers precisely. I could provide those to you, but it would be between 11 bank staff and 12 bank staff, which would be approximately
15%, maybe.
Yeah.
About 15.
Yeah.
20%.
But
why is it as high as that?
Some of those bank staff, at the moment, because of our issues we have in the emergency department, where we're having difficulty placing patients in a timely fashion, we bring in additional bank staff to care for those patients. Now, I would prefer they weren't being cared for on trolleys in the department, but those who are there waiting for a bed need to be cared for, so we would bring in additional staff, which is over and above our complement. So, for example, for January of this year, As I said, our staffing at that time was 87.5, but we had the equivalent backfill of 103 staff to cover for absences and treat people who are waiting.
Clarity of the numbers. You said you have 87.5 moving to 100.
Yes.
But there's been an announcement of 40 new staff.
Yeah, but
So how do the numbers work?
25 of those are for the AMU.
For the acute medical unit.
Yeah.
So you know, it's already in existence, but
So I don't understand.
so it's already there. I thought this was something new that was happening.
No. The new staff originally, as I said, we had 87. We're going to more than that. So the 15 staff are new, but we also had recruitment to replace vacancies as well. But when the department is busy, we will bring in staff over and above our funded staffing level.
So the 40 new posts is actually 15 new posts. Is that correct?
No, it's 15 new posts for the emergency department.
In the emergency department and 25 in the acute medical unit.
Yeah.
How many are currently in the acute medical unit?
Oh, in the acute medical unit, at the moment we have, prior to our investment, we had 7.
How many have you today?
Today I have 88, but we've recruited new staff in. The original staffing level was 75.
What I don't understand, you have acute medical unit at present and you've announced 25, and there's a total of 87 staff in this overall area.
Because we've had recruitment.
No, sorry, I think there's a confusion here.
Yeah, there is.
There is. The emergency department and the acute medical unit are two separate areas, two completely separate areas. We have recruited an additional 15 staff into our emergency department area, and we've recruited an additional...
Already?
Well, we're in the process of...
On top of the 87 that you have cited there.
Okay. The announcement was last week, wasn't it?
Yes.
So have you...
Yes, we were in a recruitment, sorry, it might be useful, Brendan. We were in a recruitment process already to recruit additional staff. Some of those are already in post, some of those are in train. We will, when the recruitment is completely finished, we will have recruited an additional 15 staff for our emergency department. I think what you're asking, right, how many are there now? How many of the additional 15?
How many above and beyond your original
have been
recruit are being announced, are, in terms of the ministerial announcement, and many additional staff will be in post as a result of the announcement recently?
Okay. There will be an additional 25 staff in the acute medical unit and an additional 15 staff in the emergency department.
Okay, I'll let it go with that. Okay, because you know, one of my concerns about Monday is when I was approached by nursing staff, and I did speak to trust staff when this happened, and I would describe it as a distressed member of your staff in terms of the pressures that they were under. I was led to believe there's one nurse and one auxiliary nurse looking after a ward in the acute medical unit.
That's not correct.
Well, I can tell you it was a highly stressed nurse who took time very briefly to make a point of speaking to me and expressing concern and the conditions in which she was working under. I wish to pass that on directly to you.
But that would be good.
I have already done so, but I wish to formally do it.
I'm aware, and our team have been supporting that nurse. I think for clarity, though, did you mean a bay or a ward? Because a ward is the entire...
Well, it was described as being 8 plus 15 is what I've noted down here. So I'm assuming it's 23 beds.
That wouldn't be correct.
Okay. When I spoke to one of your staff members, I'm not sure if it was Brenda or Bernie, or indication was that there was a shortage of banking staff who hadn't turned up, or you weren't able to get banking staff.
Yeah, I mean,
was it yourself that I was talking to?
No, it wasn't. But I will say to you that the purpose of using bank or agency is to fill short-term vacancies, and people who work bank or agency work that at their own volition.
What do you do when there's a shortage on the recommended rota number of staff members that you can't fill in one of these? This is acute medicine, and there's a shortage. What do you do in that situation?
There's a protocol that's...
Yeah, there's a protocol. We try to obviously fill those vacancies from within, and certainly the work we've been doing from Ward 7B and C opening last year, we increased the nurse to bed ratio, we call it. We increased it again in October, which was what the recruitment was based on, and then and we had a process to increase it further. The RQIA recommendations made other suggestions with their preliminary feedback, so we've taken further action, hence the additional staff I've spoken to you about. But on a day-to-day basis, you have a rostered number of staff and support staff for an area. If people call in ill at very short notice, then we have a team in place on all of our sites called Patient Flow, who will try to allocate additional nurses. We do ask our staff to work additional hours. We also will ask, if we have more notice, that staff change their rotas. And that is the day-to-day way in which we manage that.
But what happens when in an acute medicine area, this is patients who've just come out of an accident or emergency. There is a shortage. Certainly, it was expressed to me there was a shortage that day on Monday. Was that the case or not?
We did have, I think we had 2 staff who had phoned in ill at very short notice, and the ward sister who you met that day was managing that within the resource that was available.
Can I say, right, and I mean, and I don't want to diminish any feedback that you've had from staff, and I'd be very keen that feedback, that we take that on and recognise that. In any ward environment, in any day, and the point that you make is an important one about this being the acute medical unit, there are operational issues in terms of staff who phone in sick at short notice, and there is a protocol that we go through to ensure that we either fill those posts or provide a mitigation in relation to providing the care in those areas. That's an ongoing operational issue in quite a number of our...
I hope you take the time to look at the Hansard's transcript of RCN who were here before you, and they'd indicated concern about burnout in acute medicine. They also indicated they have recruitment issues, they have issues in terms of how you redeploy staff to other areas. So there's a number of issues, so I hope you will take a look at that, so that there is not staff burnout, and that you minimise the number of agency workers, so that there are effective teams working together.
Well, we will do.
Might I just say, we work very closely with Royal College of Nursing around staff support, both at a local level within the trust and at a regional level, and certainly. In fact, I had a staff meeting with AMU staff last night, and it's very important we keep those discussions at operational level within the department, but also that we have a mechanism to escalate concerns. And certainly that's what we're very keen, both in relation to all of our departments, but in relation to the issues you have raised around the emergency department and AMU. So we work very closely with the Royal College of Nursing to provide staff support, and our other trade unions, I have to say.
But I'll give you an assurance that we will look at the transcript of the evidence that was provided earlier today, and we will take it seriously.
In terms of the consultants, they were saying that the pressures were largely predictable, and as we were there on Monday, we saw in the outcomes area the 9-bed trolleys were already full, and I don't know where the next person that goes to A&E was going to be placed, no doubt in a corridor somewhere, and that this is normal for a Monday. It's got to the stage that this is normal. So my question is, what are you doing so that this is not normal? And in particular, why are there not beds available to receive patients who come into your or who are going through your accident emergency unit? That stops the flow in the hospital. It stops functioning.
And I'll deal with that on a general basis then, Roy, and I'll ask Tony and Bernie to maybe provide some of the more detailed aspects of what we're doing. I mentioned as part of my presentation about 7-day working, and that part of what hospital systems want to do is to even out the work and the flow across a 7-day week. Currently, that's not the case. So on a Saturday and a Sunday, we do not have our senior decision makers on the floor making decisions the same way as we do on Monday to Friday, and that just doesn't apply in ED. It applies in other parts of our system. But that's not to say that people aren't working 7 days a week. They're just not working over the same period of time, 7 days a week. What that means is, and you're quite right, and ED consultants are quite right, what that means is that we find it's more likely to be the case that we will be under pressure on a Monday and a Tuesday, because we haven't had the discharges over the weekend that we would normally have on Monday to a Friday, the decision-making that's being taken is being taken by more junior staff and takes longer sometimes to make the decisions. So it begins to build up over the weekend and manifests on a Monday and Tuesday. What we're doing now, and what we've started to put in place, is we've recruited additional ED consultants with the intention of deploying those additional consultants on a Saturday and a Sunday for a longer period of time, so that we have our senior decision makers over the weekend for a longer period of time. That will only work as long as we also have the discharge at the back door working in a way that ensures that we optimise discharges over 7 days a week. I know that our Commissioner has identified 7-day-a-week working, and right across these islands it's been identified as an important aspect of delivering hospital care in the future to relieve pressures. And we're working to do that with our Commissioner, and we've put in we'll be putting in additional medical staff to do that at the weekends, particularly in our ED.
Are you operating at above the level of bed occupancy rates as recommended as optimum levels?
Our bed occupancy at times would be above an 80% occupancy, which would be described in some cases as the optimum levels. We would be working above an 80% bed occupancy, and particularly in the early part of the week on a Monday and a Tuesday.
Other issues in terms of the consultants, they had highlighted the need for diagnostics at weekend, and
that's right.
Also that emergency medicine should be, their views and concerns should be better reflected at a leadership level. Why is there no emergency department clinical director within the hospital?
Well, we would like there to be. We would like one of our emergency consultants to come forward and be a clinical director. There was a clinical director for a period of time, but there isn't now, and we're very keen to encourage one of our emergency consultants to be a clinical director. It's no lack of willing in relation to management to have a clinical director and a clinical leader in the emergency department, believe me. Can I also, you mentioned diagnostics at the weekend, can I ask Bernie to outline some of what we're putting in place in terms of diagnostics, particularly access at the weekends as well?
Could I just address that issue about the clinical director in the emergency department? We have 2 emergency departments, one on the Mater and one on the Royal site, and we have a clinical lead who is an emergency department consultant who is taking the clinical lead roles on both sites. And up until the end of March, we had a clinical director in emergency in the emergency department, but his background wasn't in emergency department medicine. However, he still had the kilts. He was a very experienced clinical director from another discipline within within anaesthetics within the trust. In relation to diagnostics, and one of the things that we want to do to put in place, we do have a diagnostic service as an emergency service across the weekend. It is a very, very busy service, undertaking CT scans, plain film radiology and ultrasound. However, that is dealing with the emergency department solely. And what we need to put in place is additional resources at the weekend over and above that emergency, and the staff are there providing that solely for the emergency department. They are. We need to put another team of radiology and radiographic staff in to be able to undertake the diagnostic tests of the patients who have been admitted over the weekend, so that their diagnostic test is not waiting till Monday and Tuesday, and therefore further decisions or discharge decisions are being delayed to Monday or Tuesday because of the lack of the additional capacity for those imaging tests.
Finally, then, in terms of your wider role, the GP out of hours service provides relatively limited support, and generally the last resort is, let's go to A&E. And I've experienced this myself, where GP out of hours couldn't actually remove 2 stitches from a wound I had, which needed to relieve pressure and give antibiotics. Are you looking at the GP out of hours service to extend what they do, so that less people have no choice but turn up at accident emergency?
We actually, this year, we have a pilot running in our RVHED where we have our GP out of hours actually co-located in our RVHED. And the intention there is a triage, that people are appropriately triaged to our GP out of hours service as opposed to coming into our emergency department. What we've actually found is that hasn't worked as effectively as we would have liked it to. in that the triage has not resulted in as many people going to our GP out of hours as we might have thought. And in fact, our GPs were a bit disappointed in that as well, and they came into the emergency department to actually case find to see if there were people who they could have been treating, and they found there weren't. So the level of illness, or the acuity as we call it, is quite high in terms of those people who are requiring to come in to our emergency department. In terms of our GP out of hours, I'm in discussions currently with a number of GPs looking at how we could fundamentally change the system. And this is not to say that this is going to happen, but this is one of the models that we're looking at. For example, that if you think that the only way you would get into the Royal Victoria Hospital ED in future is in a blue light ambulance. The only other way you get into the ED, so you don't walk in off the street, you don't drive in. The only other way you get in is through a primary care stroke secondary care triage system, so that people who are walking in walk into a primary care triage system, and through that system then they're filtered in relation to attending the ED. You can't just walk in off the street. That already works in Norway, and we've looked at that in terms of how that works in Norway, and we're looking at that as a potential model for Belfast. Now, that's something that wouldn't happen overnight. It will take a period of time to plan and get in place, and it's also something that we would be looking for our community stakeholders to sign up for in terms of the change that might mean, because in Belfast that would potentially mean that we wouldn't continue to provide our GP out of hours services in the same places that they are now.
Okay, right. I have 3 more speakers. Jim, Kieran and Maggie. Jim first.
Colm, you must be a soothsayer, because the Norwegian situation was exactly what I was about to bring up. Okay. And I was going to suggest that as a solution and claim it as original thought, but unfortunately you got your retaliation in first. Could I just say on that seems to be a very good idea, because there's various estimates between 30 and 40% of people who present themselves as walk-ins into A&E shouldn't be there at all. And you have to have some way of getting them out of the system so that the genuinely ill people who come in the ambulance can be treated. Is there not a danger, mind you, that if the public learnt that what you'd have is far more call-outs for ambulance?
There is that possibility. I think the Norwegians found that initially in their system, that their primary care practitioners used ambulances more than they had done before. But I think that's about learning from that lesson from them in the context of how we manage and put in place controls and levers in the system to ensure that that doesn't happen. But you're right, it could lead to an abuse of the ambulance service in terms of getting people into your ED. But that would require people actually to be sending people in a blue light ambulance that don't necessarily need to go. So.
And if you have any idea, David, at the Royal at the minute, what proportion of your walk-ins shouldn't be there? Have you any sort of recent figures on that?
I looked at Bernie and Brenda. I know our figures weren't that. We were slightly lower in terms of the 30% figure, yeah, because of the regional trauma centre and because of the acuity of the people who would tend to come to the Royal. But we still had a fairly high proportion. It would have been over 20%.
Yeah, over 20%. Though I think it is important also to differentiate the emergency nurse practitioner minor stream, because as we've already said, they are minor injuries, but those people maybe need a diagnostic or need treatment and are turned around very swiftly. But within the other people attending, it would be in the mid-20%.
If you could take that out of the system, is that solved? If you could take those sort of numbers out of A&E, would that?
It may not, because maybe if I said to you that some of those people who would be attending, who would not require admission, don't necessarily put the pressure on the system. The people who put the pressure on the system, quite rightly, are those people who the doctor has made a decision to admit. And when the doctor makes a decision to admit, then it's those people who we need to get into the system. In Belfast, our admissions have gone up over the last couple of years by 8%. And there's a phenomenon around fractures, which we're still trying to discover what it is. But fractures have gone up by 9% in the last year. In terms of admissions for fractures, have gone up by 9%. So those people would be coming into the hospital system and being admitted anyway. What it would do for us, Jim, is it would allow us, if we were able to take away those primary care type attendances and people who don't require to be in ED, it would allow us to put more resource into those areas where people require either treatment or admission in our hospital system.
I've looked up a couple of stats here, which I think are quite worrying. That there are actually 69 more middle-grade doctors now than there were in 2011, despite all the problems. And that's 20% up on May 2011. So clearly, even though you've been running fast, you're actually slipping backwards. So it's not that we don't have more middle-grade doctors, we don't have enough middle-grade doctors.
That's it. We don't have enough.
Right. And there are 400 vacancies of middle-grade doctors in the UK at the minute. So the situation is actually worse than you're portraying it.
Well, it is across the hospital system. If I was to say to you that it's well known now that in England, for example, some trusts have paid £3,000 to doctors to cover shifts because of the vacancies they would have in their rotas, both in middle grade and consultant grade. We haven't done that. We have not, and that's the point about contract. I'm sure if we were going to pay some people £3,000 a shift, they might come in and work for us. And it is not that we don't believe is the right way to deal with this issue, because it's not a good use of public funds in terms of paying those types of rates. That is happening in different parts of England, and they're being quite rightly, I think, criticised by their own public accounts.
Well, it's not directly relevant. Obviously, I've had to face the wrath of people in South Down over the Down and Lagan Valley issue. But one of the points was made there is that the solution to this problem is to engage the services of doctors from Europe, particularly Eastern Europe, who've got the language proficiency. Now, is there any attempt being made to fill that very large hole with European doctors?
No, I can say we have had in a number of specialties, including ED, attempts at recruiting in Europe, but it has not been successful. We have never really recovered from the loss of people coming from India, Pakistan, those traditional countries that supplied us very effectively with doctors. Europe does not seem at the moment to be offering us a solution, and we have tried. We've used recruitment agencies to go to job fairs in Europe, and it has not proved successful. And the other thing, again, not all doctors working in other parts of Europe have trained in a system similar to the British or Irish system. The British and Irish systems are actually remarkably similar and quite interchangeable. But when you go to Europe, you find that people's training is different, and it can be very difficult to be sure that you're getting exactly what you require.
We can't recruit in the Irish Republic.
We can, yes. Well, but then we're fishing in a very small pond there, and we're competing with their system, and that has not been a rich source for us. A lot of reasons.
It may be because their remuneration has changed in the Republic of Ireland, so it would not have been financially attractive for doctors in the Republic of Ireland to take jobs in the north. But
maybe we could recruit in Sussex. Is that a good place to get middle-grade doctors? Okay. Thanks.
Jim, could I just make one more point, sorry, Chair? Our consultants tell us that it is more difficult to recruit to work at middle grade in the Royal because of the acuity of the patients. We have sicker patients, and it tends to be often busier. And I am being advised that it is not in terms of workload and the level of skill and potentially the demands on individuals the easiest place for us to keep people.
Okay.
The other very worrying stat that have been given here is that there's been a 60% increase in the number of doctors emigrating to Australia in the last 4 years. And what is the Belfast Trust doing, or what can you do to stop that hemorrhaging of staff to the sunny climes of Sydney or Bondi Beach or whatever?
John, I can answer that question. I mean, a lot of junior docs, indeed some of our consultants are going there, and indeed go to other parts of the world. We've, by and large, always encouraged that, because they, if it's part of their training or part of their development, we want them back. There's always been a very strong tradition of going to the States. Australia's been a more recent phenomenon, and we're very keen on that, because you do not want doctors working in Belfast or in Northern Ireland who've never been outside Northern Ireland. That becomes incestuous, and the patients, we all suffer. So let's encourage it. The issue for us is getting them back, and I think we're reasonably assured that those doctors from ED have recently been to Australia, are coming back, and indeed our clinical lead now in the Royal, Sinead Campbell-Gray, had to spend a period of time in England and in Australia, and has benefited from that, and we're now benefiting from it. The secret for us is not to stop them going, it's to make sure that we're offering attractive enough jobs to get them back.
And I mean, even in the recent cases that have gone from the Royal to Australia, it was on the basis of a career break. But in fact, had we not agreed to the career break, we would have been afraid that we would have lost them permanently. And the basis of allowing a career break, they have given a commitment to come back.
Okay, thank you. Kieran?
Yeah, Chair, thanks. I'm glad to hear, Colin, your response to Jim in relation to the putting extra pressure on the ambulance service, because already we know ambulance staff are under immense pressure, so I'm glad to hear that. I mean, what I'm speaking about here has been covered. I mean, I think it was Bernie has spoken about it, and it's your trust have operational control over both health and social services in your own trust. A major issue appears to be the timely discharge to the community to free up beds in hospitals. And Colin spoke about that way early on. Why is the Trust not better coordinating with the social care side of the House, given that it comes under your control?
Yeah, and you're quite right. And if anybody can make integration work, it should be us, because we have it within our control, both health and social care. And there is a lot of close working in relation to health and social care. In fact, again, back to the 7-day working, we're now providing social work services in our hospitals at the weekends so that we can facilitate weekend discharge as well. And we're able to do that again because we employ the social workers. We also have, if you like, reaching from our community care for people who will case find for people who have particularly complex discharges, who will then be discharged into the community as well. And we have, as I mentioned earlier, a very focused discharge project, which is looking to see how we can improve those processes even more in relation to making that discharge even more effective.
Okay. I'm going to just finally say, to back up what has been said already in relation to, and you did say you were going to get a copy of the presentation we had before, because it was very distressing in my point of view, from our point of view, to hear what, and there has been a number of inconsistencies for what they have said and you said, so that has got to be sorted out. And I would appeal to you as directors of the Belfast Trust to ensure that the nurses are better provided for, because otherwise we're going to go from crisis to crisis.
Can I just say, Chair, that, as I've said already, we work very closely with our trade unions, including the Royal College of Nursing. In fact, I'm actually meeting with Janet Smith on Friday of this week to look at how we can do this, both at a support level for our staff on the ground, but also in the planning of things going forward as well.
And that's a very important. The forward work planning seems to be non-existent, for a long time. And if that was overcome, we might help to overcome the problems that we're going through.
Okay,
Thanks.
Mickey?
Yeah, thanks for the presentation. I'll try and be as brief as possible. It follows on in what Kieran was saying, because Dr. Stevens had mentioned about 700 people, if possible, to keep them out of the acute end of it. The Royal College of Nursing was saying at the previous presentation that community services aren't being developed. So it's back to vision without action. So obviously that has to be worked on, because, as you said, Colin, you're responsible for both things. But the other thing was just in the A&E. I know in Daisy Hill the out of hours is in the hospital, and that seems to work quite well, because people have a confidence probably in actually going to the hospital initially, and then it does take some pressure, I think, off A&E and the emergency department, so that seems to work well.
That was my decision, by the way, Mickey.
Sure it was. That's when you were in the Southern Trust, yeah. The other thing, it was interesting you mentioned people first. In my view, it turned out to be a euphemism.
Yeah.
Because had it been put into operation the way it was supposed to, then it may have alleviated problems down the road that you're now experiencing. I don't know if you'd agree with that or not, but it just seemed to me, I remember it well, and it was fanfare at the time. Just the other thing I would say, in terms of the serious adverse incidents, I've spoken to one of the families here in Belfast. I remember one of the families, because there was some connection with the family, and they were not happy that they felt that down, they hadn't been communicated with the way they felt that they should have. Like in some cases, they felt they hadn't been communicated with at all by the department and the trust. So maybe it's something to address. I just wanted to make that point.
No, and I'll start off with an apology for that. Mickey, that is not something we wanted or that should have happened. I would apologise to that family, and I'd be happy to do that in meeting with them.
Okay. Sorry, go ahead.
No, I was just going to mention, Mick had mentioned some of the community infrastructure, and it's just to give an assurance that we are looking at the community infrastructure to support discharge. So we've just invested in additional what we call step-down beds. Those are beds where people can step down from hospital for a period of rehabilitation and inpatient care outside a hospital non-acute setting. So we've just invested in additional step-down beds. And the pilot that I mentioned earlier, the acute care at home, there are other proposals that are around which we can share with the committee rather than going through them today, which have also that emphasis in them, which is about caring for people closer to their own home rather than them requiring to go into hospital. The other thing I want to mention about transforming your care, and I'm sorry we're bringing it at this late stage, is it covers more than just hospital services. So while we've talked today primarily about hospital services and the impact, it covers mental health, learning disability, older people's physical disability, children's services, not as much as maybe it could have, but children's services as well. So it's much wider than just the hospital aspect.
Could I just finish by saying it's not all doom and gloom in one way, because Belfast Trust have no statutory residentials as such. There was a furore back in April and May. Belfast Trust seems to have managed that without all of that hype and furore, and was done in a measured way, I think. Because I know, talking to some of our people, for instance, in West Belfast, how that was done, and that seemed to have been managed in a constructive way.
The principle, I think, in Belfast was that while we're planning for the future, elderly, older people in the future who do not want to go into institutional care but prefer to stay longer behind their own front door. That's the planning, and that's the supported housing and those schemes that we're putting in place. We also recognise there was a need to actually respect the people who are currently in residential care and to assure them that they could remain in residential care for as long as they required to. So what we did, and this has been slightly controversial, I think, in the recent consultation, but we did it back 4 years ago. What we've actually done is ensured that anybody who requires residential care gets it. But in terms of the statutory residential care, we ceased admissions to our homes. And it has never been the case that anybody who has required a residential care place hasn't got it or hasn't received. So there is no unmet need.
Reasonably well. The problem
there's no unmet need.
Has in other areas. Maybe you should have passed on your expertise, if that's the right word, in that area, because it didn't work back in April and May.
And people are now looking at that particular way of ensuring that people who currently are in residential care have their place for as long as they want it and plan for the future, because that was the two aspects of this that needed to be done.
But it meant that TYC failed at its first hurdle, and that's part of the difficulty.
But Cherry Tree Lodge, is that not?
That's one of ours, yeah.
Is that not under threat? I mean, as far as I know.
I need to take this conversation back, because far be it from me to say we're not here to pat the trust in the back.
It's one of the homes that no longer have admission.
Oh, that's right.
Right, okay, folks, at this point, and I know Fergal had a small question, but just let me come in at this point, because I'm going to have to leave, unfortunately. Just specifically, in bringing this to a conclusion, just to answer the direct question, do you think that emergency care is in crisis?
No, I don't think it's in crisis. I think it's under tremendous pressure, and we know the reasons for that. But I don't think it's in crisis.
And what is the situation in it today in terms of the Royal?
At this point, I would need to could look at my phone, Chairman, and tell you the Royal ED is under pressure and has been under pressure for the last 2 or 3 days. But at this, when I came to this meeting, what I could tell you is that we had about 30 people in the department. In trolleys?
No.
In total. In total, 30 people in the department in total before. But there were 9 people who had waited for longer than 12 hours at that point.
Well, can I just say that, as we're having this conversation, I'm being contacted by staff who are indicating that effectively ED has not stopped since Sunday, that there's patients that have been waiting over 25 hours for a bed, and that patients have actually emailed the minister. So I don't know. I'm reflecting on what
Okay.
I'm being told, and I'm putting that straight back at you. You know, if that is the situation, surely that is crisis, and surely that needs here and now interventions.
Yeah, and there will be here and now interventions, but I mean, you have the information in front of you, Chairman, that's been texted to you or whatever. I don't have that information currently. When I last looked at the ED, that certainly wasn't the situation. But as soon as we are finished here, we'll certainly look at that.
Okay. Well, can I ask that you respond urgently and come back to me on that, because I'm bringing it to your attention now. And if it is the case, it's a very serious case. I know Fergal wanted to come in on a
Just a
small
couple of
point.
points. Are the problems experienced at the Royal also being experienced at the Mater?
Not to the same degree, but there is pressure at the Mater as well, as there are pressure on other hospitals in the Northern Ireland system.
Could the Mater be used to reduce the pressure on the Royal?
What we tend to do, Fergal, is that the Mater, because of the pressure it experiences, and it's a much smaller ED, we tend to allow the Mater, if you forgive the phrase, to consume its own smoke, to actually ensure. But if there was additional capacity at the Mater, we would use it. But it tends to be the case that the Mater is able to actually deal with its own pressure, and therefore it means that we can concentrate on the Royal Victoria Hospital.
And finally, will the City Hospital Emergency Department ever open again as an emergency department?
I can't answer that. That's a question for the Minister in terms of the final decision. What I can say to you is our advice to the Minister would be that it shouldn't open again, that our preferred model would be that we would continue to have 2 emergency departments, which would be the Mater Emergency Department and the Royal Emergency Department, but the final decision is with the Minister.
Thank you. Thank you, Chair.
Is that all? Folks, this is actually thank you very much, Colm, and this may be the last time we'll see you before you go. I was really joking when I said we'd raid Sussex for middle grade doctors, but maybe there'll be a surplus available when you take over. To you and to your colleagues, this is a difficult issue. Thank you for being here and taking the pointed questions we raised with you. Thank you very much.
Thank you.
Committee members, this has gone on a bit longer than we anticipated. I'm in your hands, but one suggestion is that you could postpone the evidence on GP out of hours to another meeting. If you're keen to go on, by all means. It's just we've had 2 very long sessions. So can I just take your will on that? What do you feel, Nicky?
Will I have a meeting here at 7, Jim?
Yeah, and I've got a meeting too.
Right, so Roy, are you happy enough we do that?
Great.
Okay. So we'll postpone that, and maybe we'll let the witnesses know that we'll revisit it at another time. We then move on to the review of waiting times. Could I ask members to note a letter from Michael Lyons, which is providing additional information on the waiting statistics on page 60. And then, could we then move on to reviewing of transforming your care and older people? Could I refer members to the briefing paper from the committee clerk at page 68? And our next oral session, the next evidence session, this will be on the 9th of April with the Older People's Commissioner. And I could suggest we take evidence also from CARDI and AGNI and the Federation of Housing Associations. Professor Anthea Tinker from King's College London, and of course from the Department of DSD. Are we happy with those list of witnesses? I think that will keep us quite busy.
Not all in one day, I hope, Chair.
It could be a long one. This is nothing. Justice only getting warmed up at this stage, I can tell you. In terms of visits, it has been suggested we should visit 2 supported living facilities. One in Belfast, which was built about 10 years ago, and one in Downpatrick, which was built in 2012. This is one I'm quite aware of. We could do this in one day, which shows that it's not that difficult to get from Belfast to Downpatrick. And I suggest that we visit the pavilions in Lisburn, which has been built by the private sector. That's in addition to Downpatrick and Belfast. Are members content with that arrangement? Yeah. Could I refer you to a copy of a response from the Minister to a written question from Roy Beggs on page 70?
Again?
Obviously making a mark, Roy. Please note that this was this response, the Minister is able to provide information on vacancies and waiting lists for each supported living facility. However, when we had officials before us on the 26th of February, they were not able to provide this information, and the committee sent a follow-up letter to the department after that session. We expect a response soon. So Mr Beggs has got in ahead of us and produced that material. So we will be expecting a formal response from the Minister on that. Could I refer you then to Statutory Rule SR 2014-56, which is the Firefighters Pension Scheme Amendment Order Northern Ireland 2014, and could I refer members to page 74. The committee considered and approved SL1 for this rule at its meeting on the 26th of February. Are members content with the statutory rule?
Great.
Can I put the motion to members that the Committee for Health, Social Services and Public Safety has considered the Firefighters Pension Scheme Amended Order Northern Ireland 2014 and has no objection to the rules subject to the Examiner of Statutory Rules report? Are we happy enough? Then can I refer you to Statutory Rule SR 2014-57, which is the Northern Ireland Firefighters Pension Scheme Amended Order Northern Ireland 2014, and can I refer you to page 82? And the committee considered and approved the SL1 for this rule at its meeting on the 26th of February 2014. Are members content with the statutory rule?
Great.
Can I put the motion to the meeting that the Committee for Health, Social Services and Public Safety has considered the new Firefighters Pension Scheme Amendment Order Northern Ireland 2014 and has no objection to the rule subject to the report of the Examiner Statutory Rules?
Great.
Okay. Can I then refer you to Statutory Rule 2014-59, which is the Health and Personal Social Services Superannuation Health and Social Care Pension Scheme Amendment Regulations Northern Ireland 2014. Can I refer members to page 89 of your papers? The committee considered and approved the SL1 for this rule at its meeting on the 26th of February 2014. Are members content with the statutory rule? Can I put the motion to the meeting that the Committee for Health, Social Services and Public Safety has considered the Health and Personal Social Services Superannuation Health and Social Care Pension Scheme Amendment Regulations Northern Ireland 2014 and has no objection to the rules subject to the report of the Examiner of Statutory Rules?
Great.
Okay. Could I then refer members to the Forward Work Programme and note it? It's on page 101 of your packs. We've already alluded to that earlier. Could I ask members on matters under matters arising to note items 13.1 and 13.2, which are in pages 104 and 106? Now, there's an issue was raised by Kieran McCarthy at our last meeting. At its last meeting, the committee discussed the provision of alternative therapies on the health service. For members' interest, the committee wrote to the Minister previously about this matter on the 22nd of July 2013, and that response can be found on page 115.
Yeah, I'm very grateful for that.
You're happy enough, Kieran, with that? Good.
This moment in time, yep.
And then we move on to correspondence. I'm moving rapidly here, folks, but if anybody feels they've been left behind or want to intervene, please let me know. Item 14.1 on correspondence is on page 119. It's a letter from the Minister regarding the Adoption and Children Bill. The Minister intends to put a draft bill out to public consultation from July to September 2014, and he aims to introduce the bill to the Assembly on March 2015. If this timetable is to be kept to, it would mean that the committee would be dealing with the adoption bill at the same time as the joint ad hoc committee made up of members of Health and Justice dealing with the mental incapacity bill. It'll be an interesting time for all committee members. And therefore the Minister is asking for our views on the scheduling of these bills. Given that the Health Committee will continue to meet weekly for the remainder of its mandate, I'm certain of that, I don't see any issues with us taking forward committee stage of the adoption bill this mandate. Dealing with the adoption bill would be our priority in terms of our work programme. Could I suggest we write back to the Minister and welcome the progress that's been made on the bill and advise him of our intention to prioritise this in our work programme, and that we look forward to engaging with officials on it prior to public consultation?
Yeah, Chair, would there be any merit in letting the Minister know how important the mental capacity bill is, justice and health? We do not want to see it fall by the wayside. I'm sure members would agree.
Well, I think Justice equally would have the same view, and it'd be up to the ad hoc committee to make absolutely certain that didn't happen. Any other thoughts on that? I mean, we're going to try and get the two through together.
Absolutely.
Because all the work seems to be piling in one committee.
Yeah.
Be paid double on this. Any Joy?
Just how many clauses is the adoption bill likely to be? How big a bill is it likely?
Chair, the Minister is indicating it could be 150 clauses.
Yeah, a bit of light reading for us all. Oh dear. Right. Could I ask members to note items 14.2 to 14.5, which are on pages 122 to 132. Then item 14.6 on page 133 is a letter from the Committee for Finance and Personnel asking the Committee to write to the Department for information regarding the Investment Strategy Project Delivery Portal. Are members content that they contact the Department? They contact the Department directly for the information required?
Great.
Okay. Item 14.7 on page 139 is correspondence from the Public Accounts Committee, forwarding correspondence received from Hugh McCloy regarding waiting times. This correspondence was previously noted by the committee at its meeting of the 12th of March. Given the fact that the PAC have sent this to the CNAG, are members content to note?
Great.
I ask members to note item 14.8 on page 145.
Yeah.
Okay. There's an item 14.9 on page 160 is correspondence from Schomburgh Public Affairs asking the committee to sponsor an event that they're organising on addiction services. The clerk has told me it's not quite clear when that's to be held, so can we note it at this stage?
Great.
And then we could come back later on. Could I ask members to note items 14.10 to 14.14 on pages 163 to 169?
Yeah, Chair, we're just the last one. Una Cruden, I think we raised this last meeting. That's a fantastic achievement for this lady. We all know Una. I don't know, should this committee be sending a letter of congratulations, well done and all that?
Yes, Kieran, I think you might have been here, but that came up at the previous meeting, and we have sent a letter to congratulate Una on an outstanding achievement.
Absolutely.
As Belfast Telegraph Woman of the Year. I think actually I may have raised that myself.
Yeah.
You did. She's doing a remarkable. I think I did.
I have no doubt in my mind.
She's a remarkable woman, and I think it was only right that we did that.
Absolutely.
Could I ask members to, and by the way, she was 60 on...
Yesterday.
Yesterday, that's right. She was celebrating her 60th.
Tell her a happy birthday.
Some of us have already done that.
Right.
Could I ask members to note items 14.10 to 14.14 on pages 163, which we've done? Could I refer members to a request from ME Support on page 55 of the table papers for the committee to sponsor an event Turn the Great Hall Blue for International ME Awareness Day. You know, we did teal green for ovarian cancer.
Agreed.
There's a few other colours some of us could suggest, but I think this one's fairly non-controversial.
I wouldn't go that far with the green.
Is this a request to the Commission or to the Speaker?
I think it's the Commission that would deal with this, but it's coming through us.
Chair, we have been in touch with the Events Office, and it can be arranged. And it can be sponsored by the committee. I think that if anybody was looking under the exterior of the building, then that goes up. Is at a higher level to deal with.
Well, we're happy that blue is non-controversial and it's a good cause.
Green could be. Are there any political implications?
None whatsoever, I think. Are you happy with that, Mickey?
Well, it's a fairly conservative colour, isn't it?
Yeah, and you're wearing a blue tie, so.
Mickey?
Right, so the committee agreed to sponsor that event, as it were. Could I advise members that the Association of Social Workers is requesting that the committee sponsor an event in the Longarry on the 12th of May. We've done quite a few of those recently and they've been very successful. Are members content that we do that? It's something rather different from the medical ones we tend to do. Okay.
Great.
Any other business? Do members have any other business? Everybody happy enough? Okay. And the next meeting then is on Wednesday the 9th of April, starting at 2 p.m. in the Senate chamber. Of course, you know what we're doing next week.
Yep.